Hello, everyone. Welcome to the 4th Annual North Sound Race and Health Equity Conference. It is so good to have you here and to spend our Saturday morning with you all. My name is Su-Ling Zhao. I'm the Community Advancement Director for Chuckanut Health Foundation. And I have the honor of saying hello and being your first hello in the room and on this microphone and supporting all of our wonderful speakers today. And I just want to open today with a gift and an offering. So I had an amazing conversation with our dear friend, Kay Knott, while we were hanging out on the side over here. And Kay, I would love to invite you up here to tell a story if you're willing. Thank you so much. So this is Kay Knott from the Upper Skagit Tribe.
Hataratu. Good morning. Gulapu siab. Skohahalitsa tatsta to all Skagit. I come from the Washington Martin Moses Jones family. I'm also Swinomish, Snoqualmie, and Yakima. I'd like to welcome you to the home of the Skagit people, where we have cared and loved for this land since the beginning. The closest band to you here is the Nukwachabish, and it's just a mile or so down the road from you. We welcome you to love and care for the land as we have for so many years, and to appreciate its beauty and all that it gives. I have one more blessing to give to you in a minute, but anybody traveled a bit this morning, waking up Saturday morning? So I decided that you guys are doing such important work. I was so excited to be here this morning. And just driving in, I kind of got wrought up about the work you're doing and how important it is and how difficult it'd be. So we're all going to do some work. I'm learning to learn some of our traditional stories. And I hope you appreciate this because you are now going to do some work. And I hope you appreciate what you learn from this. So everybody has to stand up as you're able. And I'm going to tell you a creation story. All tooty too hawk, a long time ago. In the beginning, the Creator went across the country and put languages all across the world. When the Creator got to here, the Creator left the most beautiful language. We can say that because it's Lashutsi, that's our language. And in the beginning, there was a bit of a problem. The sky was very low, and tall people would bump their head, and sometimes they would jump up into the sky, and sky people would jump down, and that was a problem. People were in the wrong places. This was a problem. So they sent out for people all across the world and said, how are we going to solve this problem? The sky people shouldn't be here, and we shouldn't be there, and it brought people from all over the world to come together and said, let's solve this problem. So they came together, and they had a problem. They didn't speak the same language. They didn't understand each other. So the elders got together and tried to decide, what are we going to do about this? We don't understand each other. And they said, if we could only understand one word, we can solve this problem. So they said, okay, let's say Yahau. Can you say that? Yahau. Yahau means let's go. So they sent all the people to the woods to get a tall pole. So you got your tall pole. Everybody has to get a tall pole. And we're going to work together because we got to lift the sky together. And we're just going to do this with this one word we know together. So in our traditions, we do everything 4 times. So we're going to start with the first one. You ready? 1, 2, 3. Yahau. Oh, The tall people are still bumping their head. They probably have a headache. And I'm pretty sure I saw somebody come. You don't want the people from up there coming down here. It causes all sorts of problems. Let's do it again. 1, 2, 3. Yah-how! Oh, some of those tall people can walk under. Let's do it again. 1, 2, 3. Yah-how! Okay. That, we got to get one more. Okay, ready? 1, 2, 3. Yah-how! Oh, we have just separated the sky world from the earth world here. And when we separated them, a person on a horse went up there, and that's one of the constellations up there, that's staying up there. But we did this together, the impossible with just one word. If we work together, we can do anything. It is all possible. So I would like to... Thank you for allowing me that. I'm learning to be a storyteller. Someday I'd like to learn so many of our stories because I think they are so powerful. Vi Hilbert, one of our tribal elders who recorded language and saved language, left these words of wisdom to our Skagit people. And I would like to share these with you today as you start this very important work, that you work together like the elders creating and lifting the sky. Gulaput si'iyab de'ishin, tigwi tabuthid tigwi tabuthid daiha tias skok chath altias lahale, askodit chath, shak siab de'ishin, utigwi tabuthid altias dialab, uthali, ukwahwal togwal chath, to all of you, dear people, we give thanks. We thank you. It is good that we could be here together today. We pray and humble ourselves to our Creator. We give thanks. We thank you that you are here. We help each other. We help each other in this way. We strengthen one another. Thank you for your work. Thank you for your open hearts to listen and to care. And may your work be successful and grow.
Thank you so much, Kay. That means the world to have a word for raising the sky together. I would love to read the North Sound ACH's land acknowledgement, to acknowledge the room that we're in, the space we're in, and the opportunity that we have to be better stewards of the history that's here. We begin by acknowledging with humility that the land we are on today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, mountains of the traditional homelands of the Coast Salish people since time immemorial. And I would love just to take another moment to give gratitude to Kay. Thank you for bringing yourself and your spirit and your stories into this room. Can we give Kay another round of applause? So I have the pleasure of being a steward to all of you today. Again, my name is Su-Ling Zhao. I am the Community Advancement Director for Chuck On It Health Foundation. And when we were getting ready for this conference, Rachel Lucy's like, hey, you should go look at the things that you've said at the last two conferences. And I was like, okay, I guess I'll go watch the old videos and figure out what I had said previously. Which was a good thing. Sometimes it's good to reflect on our remarks in history, right? And I was trying to figure out how we answer the question of why we're gathered. And I'm struck by the idea of this conference being about critical connections and learning. Learning through facing data about population health outcomes and recognizing that numbers are not reflective of the fullness of the lives that we lead and of our communities. That our stories of our communities are where there is an opportunity to delve into the daily conditions and to seek solutions that address health disparities in the North Sound region. It's how we can celebrate the brilliance and the beauty of our communities and of our neighbors' lives. When I think about my movement, elders as a community organizer, I spend a lot of time thinking about Grace Lee Boggs And I spend a lot of time thinking about her words, that movements are born of critical connections rather than critical mass. And I think that that's the opportunity here. At Chuckanut, one of our big values is relationship and making critical connections in that moment in 2021 with a group of healthcare professionals that were organizing like community organizers within a healthcare system to address the disparities in the health outcomes that we see in our region was one of those critical connections. And those healthcare professionals were moving so that way we could take care of our neighbors better. And it's been an honor to be part of an organization that gets to be a trellis. Like, we aren't building this. This is a seed planted by community, and community grows in the way that it is meant to grow. And the ideas and the thoughts of the organizers that started the North Sound Race and Health Equity Conference are spectacular. And oh my goodness, what amazing connections will be born today, and what amazing seeds will be planted. So as we learn together, we have an opportunity to see where we have direct power to make change today. We also have the power, also have those moments where we get to see the power we have to influence our systems and impact healthcare equity. This space today, we invite you to deepen your commitments to change alongside one another and to make those critical connections. So today, we have a keynote address that's about recognizing our own individual power and influence to identify actions to deliver more equitable systems of care. We'll have a break, because we love a break, and we love those moments where we stretch and we take care of ourselves. We'll be bringing ourselves back into a community of care panel where we can see that care ecosystem that exists in the North Sound region, how we work collaboratively to create a better ecosystem of care for our community members. And then we will have a meal together. We'll nourish ourselves and nourish our ideas and make more connections. And then we'll come back to learn about mentorship and allyship and what it means to foster a new generation of care in the North Sound region. And then we'll reflect, we'll close, we'll have that last moment to make those critical connections together. And so throughout the day, I just want to remind you about a few housekeeping things. Restrooms are over to the left, that away, and Dr. Nyame is dodging me pointing towards the restrooms. I see you. We invite you to take care of yourself. If you need to get up and stretch, I know sitting, sometimes you're just like, wow, I can feel that in my knees. Go ahead and stand up and stretch. This is about us being together authentically and with one another. So please take care of yourself. We are doing some filming for the sake of maintaining this amazing archive and honoring this work and capturing this work that we do today. And there's a small nook in the back to the left if you need to take a moment to breathe, take a phone call, step out, and process. And then I also have the honor of reminding everyone in this room that to receive your CME, please remember to fill out the evaluation at the end of the day. We have the QR code for those evaluations electronically on all your tables and by the door. And finally, I get to thank our sponsors. So all of this work is made possible through the generous contribution of a variety of different individuals and organizations: Divinity Health Consulting, North Sound ACH, Family Care Network, Peace Health, Skagit Regional Health, Unity Care Northwest, Northwest Washington Medical Society, Mount Baker Foundation, the Community Health Plan of Washington, and Chuckanut Health Foundation. And lastly, I get to introduce one of the people who was a critical connection for me, a mentor, an icon, a dear heart, the only person that's ever promised to take me horseback riding, a woman who reminds me of what it is to be a fierce and loving mother that also honors herself. And that is Devin Nixon.
Good morning. When I stood on this stage last year, I was 2 weeks post-op of a lumpectomy for breast cancer. I didn't share that at the time. It was a scary time. Just wanted to keep doing the work we were doing and not think about that. But 2 months prior, at World Cancer Day, an event put on by the Sierra Sisters, which is a breast cancer support group for African American women, I was introduced to a couple of people who would change not just my trajectory as far as being a cancer patient, but inspired me so much in this work. I finally got up the nerve to reach out and ask them to be a part of our conference today, and was shocked and amazed, as you all will be when you hear them speak, that they agreed. It's my honor to introduce our keynote speakers. Dr. Yaw Nyame is an assistant professor in the Department of Urology at UW School of Medicine, specializing in urologic oncology and general urology. He believes in a team-based approach to cancer care and has a research interest in healthcare disparities in urologic cancers. Dr. Nyame's team has been studying racial inequities in prostate cancer care, aiming to improve patient outcomes and quality of care. He completed his medical degree at the Feinberg School of Medicine in Northwestern University and his business degree at the Kellogg School of Management. Dr. Nyame completed a fellowship at the University of Washington and joined the faculty upon completing his training. Dr. Paula Houston is the Chief Equity Officer for University of Washington Medicine and Associate Vice President for Medical Affairs, University of Washington. She's also an affiliate professor in the Department of Family Medicine at the UW School of Medicine. Previously, she held faculty appointments at Antioch University, Seattle, and served as CEO of Sound Generations, the largest nonprofit in Washington state providing services to seniors, adults with disabilities, and caregivers. Dr. Houston's earlier roles include Executive Director of the Meredith Matthews East Madison YMCA, Clinic Manager at Carolyn Downs Family Medical Center, and leadership positions with Public Health Seattle and King County. She has consistently led equity, diversity, and inclusion efforts to improve service delivery and outcomes for marginalized populations. Dr. Houston is actively engaged in her community, which I can attest to, serving on several nonprofit boards and 2 City of Seattle commissions. She is also a recognized powerlifting champion with 11 national and 6 world titles. In 2012, she was inducted into the USA Powerlifting Hall of Fame. Dr. Houston holds a BS from Syracuse University, a master's degree in health administration from the University of Washington, and a doctorate in educational leadership from Seattle University. After meeting them last year, I did what a lot of fangirls do. We go to the internet and we say, who are these people? What are they doing? And I was equally blown away in my research about the 2 of you and seeing what all you do in your communities. I've been inspired by you. I'm so grateful for you to be in this room with so many people I don't get to spend a ton of time with, but when I do spend time with you all, we're doing important work, and you'll hear and see more of that today. It's my pleasure to introduce our keynote speakers. Thank you.
First of all, I'm really happy there was a step there because I realized that I wore a dress and I was like, ooh. Well, thank you so much, Devin, for that lovely introduction. It is really, really an honor and a pleasure to be here, see some faces I haven't seen for a long time, and lots and lots of new faces. So I'm going to go through a presentation and hope we'll have some time for discussion as well. So, I've named this Our Journey to Health Justice for UW Medicine, Implementing Healthcare Equity at our organization. I have nothing to disclose. So today we're going to go through our framework and how we launched our healthcare equity work at UW Medicine. We'll talk a little bit about some of our key activities and our programs, and then talk about how we really integrate equity, diversity, and inclusion work into the total employee experience. And we're focusing on the employee experience because one of the things we realize is we don't have a workforce and students who are ready to take care of our patients and feel cared for and valued and the way they belong, then we're not going to be able to do the best for our patients and our communities. So who and what is UW Medicine? Some of you may be familiar with us, some of you may not be. We are large and complicated. So this wheel kind of breaks it down. So all of the items in purple are our fully integrated units and organizations. So we have Harborview Medical Center. Many people, that's the first thing they know. That's our level 1 trauma center. Valley Medical Center down in Renton, UWMC, which is right on the campus. Our UW Medicine primary care clinics, our network of 13 clinics, UW Physicians, our physician network, our School of Medicine, Airlift Northwest, and then the other one that I will point out is Fred Hutchinson Cancer Center. Probably some of you know that there was Seattle Cancer Care Alliance, and then we recently came into a new agreement and integration with Fred Hutch. So the name has been changed to Fred Hutch Cancer Center, and they are much more integrated and as part of the University of Washington. So just wanted to give you a bit of an idea of how large we are. We are about 35,000 people, across all of those organizations. So healthcare equity. How did we decide we were going to start a very intentional focus on this? So the mission of UW Medicine, encompassing all of those organizations that you just saw, is to improve the health of the public. Very short, 7 words, very straightforward. In 2017, a grant had been received by UW Medicine from the Centers for Medicaid and Medicare Integration, CMMI, that was focusing on transforming clinical practice. And to their credit, and this was before I got there, leadership realized that, well, if we're really going to focus on transforming clinical practice and looking at better outcomes for our patients, we really ought to focus on those patients who we already know aren't doing well in our system. Those folks that are experiencing the most inequities, those folks that we already see when we look at our data, have the biggest health disparities. So they decided to come up with a healthcare equity blueprint. So a large group of people, both internal leaders, external leaders, got together, developed in 2016, and then launched in 2017, the UW Medicine Healthcare Equity Blueprint. Its vision, as you can see there, to be a national model for healthcare equity and reduce disparities in healthcare delivery. 3 objectives, focusing on the workforce first, how we engage with our communities, and then how we were going to deploy targeted clinical quality improvements. 2017 is when that was completed, and the first thing they decided to do was to hire somebody to implement that, and that was me. So I started my journey at UW Medicine just as the Director of Healthcare Equity, and my work at that time was focused just on the health system side, which is what this blueprint was focused on. And then in 2020, our Office of Healthcare Equity was launched. Before that, there had been an effort on the medical school side that was called the Center for Equity, Diversity, and Inclusion, and their work was focused on the experience of underrepresented faculty and students, all the while I was doing work on the healthcare system side. About 2019, leadership decided, you know what, we should bring those 2 efforts together. So we'll begin to put a plan together. We've got to get a work group and a committee and charge the committee, all the complicated things we do to start doing work so that we can have more effectiveness, efficiency, and really, drive this work in a more robust way. And so that group got together in the fall of 2019, and they met once. And they were scheduled to meet again, and then 2020 hit. And we all know what happened in 2020. All of the things that we had been talking about in inequities were highlighted. And we were seeing, greater hospitalizations, greater deaths with all of the focused communities that we talked about for healthcare equity. So that really nice, thoughtful, strategic plan that they had to bring these two efforts together from the health system side and the school side kind of went out the window, and they just said, we need this Office of Healthcare Equity now, and Paula, you're gonna lead it. And I went, okay, let's go. So we did. And we came together, and that's just a picture of most of the folks in my office. And we came together in 2020 to begin to really advance this work across our system, very much starting with our focus on how we were going to improve outcomes for folks during the pandemic. So our mission in our office is to reduce the disparities in healthcare by educating health professionals, informed by principles of equity, diversity, inclusion, and justice as we strive to become an anti-racist organization. So really looking at what our overall mission is and just furthering that, making us an equitable place to learn, work, provide, and receive care, and to be a national model in healthcare equity and provide local and national leadership. So who we serve. This is kind of our overall arching framework for how we do our healthcare equity work. We look at our work as serving students and learners, faculty and staff, patients and families, and of course, our community. We know healthcare equity is broad, so we need to engage all of those people. We have multiple folks who have vested interests. Those are all of our partners. We like to apply human-centered design for things. That means always engaging the people for whom you are serving, who's going to be affected in the work. We want to examine the work through their eyes. And it's collaborative leadership and collaborative accountability. We cannot do this just out of our Office of Healthcare Equity. We are about 23 FTEs, and that's about 31 human beings. But again, we have about 35,000 people, plus our communities that we serve. So we really want to make sure that everyone knows that this is a collaboration, a partnership in order to gain the best outcomes. On the School of Medicine side, we decided it was time to upgrade our healthcare equity blueprint. So we now have healthcare equity blueprint 2.0, and we're actually about ready to start healthcare equity blueprint 3.0. But along with focusing on the workforce, our clinical quality improvement, and our community engagement, we've added now our learning environments across the school, looking very specifically at quality improvement, make sure that QI is a part of all of our efforts, and our EDI efforts are a part of all of our quality improvement work. And then we have an area that we're calling strategic leadership and strategic operations, which is how we are talking about our work, how we are advancing the work and connecting with people outside of UW-Medicine like this and on the national level. And that just, I thought it would be good for you to see kind of how we are organized in our Office of Healthcare Equity. We do have people to do the work, and it's still not enough people to do the work. We still feel very much like we're a growing office because as we started in 2020, as I've said, we were sort of building the airplane while we were flying it, and now I kind of feel like we're at our cruising altitude, but we're not quite there yet. So some of our key activities that we'll walk through, talking about our medical education, our EDI training, we have an equity impact review tool, our bias reporting tool, we have brought restorative practices into our work, and then we did an equity, diversity, and inclusion climate survey that I will walk through. So our learning environments. The reason I started with that is that we are an academic medical institution, so we are a learning institution, and how we bring our learners in and how we are, how they are experiencing their learning environment and our learning processes really affects how they're going to become clinicians and how they're going to be back out in our communities, and how they're going to be able to serve our communities. So just two quick things. Obviously, we're a huge school of medicine, but I just wanted to highlight two things that I think are really important in terms of our equity work and how we work in our communities. And the first one is our ecosystem development. We used to call them pipeline programs. Sometimes they're called pathway programs. But those are programs where we go out into our community and we're engaging young people as young as elementary school in STEM and letting them know that there is a pathway to coming into healthcare for them. And so we do that for our Center for Workforce Inclusion and Health System and Equity, or our WISE program. And so again, that mission to increase representation from communities traditionally underrepresented. We have several programs. Some of them you may have heard of. The largest and oldest one is called our Summer Health Professions Program, or SHPEP. We do that in partnership with our School of Dentistry, our School of Public Health, and that is a 6-week-long program where we bring students on campus for an experience where they can just experience a lot of the health sciences. The other one is called Doctor for a Day, and just as it says, we bring high school students in, and they get to shadow and do hands-on kinds of activities where it is a doctor for a day. We've been talking with all of our academic departments about increasing that work, particularly our research and graduate education departments, which are our biological sciences, biomedical sciences, and wanting to expand that because we have a lot of young people where they think of healthcare and it's like, well, doctor, nurse, that's it. Not realizing that there are lots of other opportunities, and so we want to really get out into our communities and do that more. And then the second item that I'll highlight there are our pathway programs. So we have medical students who enter in, and they can choose a pathway that allows them to focus on a specific community or population. Sometimes it's a community that they are a member of, and sometimes it's a community that they just want to learn more about or have some affinity with and want to learn how to better serve those communities. So we have four now. Our Black Health Justice Pathway is our newest one that just launched this year. Our Latinx Health Pathway, our Indian Health Pathway, which has been around for almost 30 years. That was our first pathway. And then our LGBTQI plus pathway. And so those are ways medical students, once they are accepted in, they can apply to be a part of these pathways, and throughout their medical school journey, then they have a very intentional focus on that work. So that's our students. So moving over onto our workforce across both the health system and the School of Medicine, one of the things that is really key is exposing people to what equity, diversity, and inclusion work is, why it's important, why what we're doing now is not working, how do we help them to have more knowledge, better language, better perspective to be able to better serve our patients and our communities. And we do that through our equity, diversity, and inclusion training. Of course, we know that is not the be-all and end-all. We don't expect anybody to, after taking our 7 hours of training, to have changed their hearts and minds, but we certainly expect that their awareness will be raised, that they will understand that their behavior needs to be different, and that we are focusing our work so that we can better serve patients. So in 2020, after our office was launched, our leadership made a commitment to have everybody in our community do equity, diversity, and inclusion training. And then in 2022, the Washington State Legislature helped us out, and they passed 3 bills mandating equity, diversity, and inclusion training. And I do think it's important to note that as you see the national landscape, we are here in our little blue bubble around this work. I've had the opportunity in the last several months to go to the American Association of Medical Colleges, or the AAMC, which is the group that academic medical centers across the U.S. and Canada belong to, and talk to colleagues who are in places like Utah and Florida and Texas and Kentucky who didn't know if they were going to have jobs when they went back home. So the fact that we are here and that we're gathering in places like this to continue to affirm that it is important to do this work and that we're not going to stop is something that we just never want to take our eye off of that. So we have had this, the luxury of being in this state, which I am very happy about. So we now have 6 training modules that we have available that are required. The first one is around identity and privilege and intersectionality, talking about why identities are important, how privilege affects the way we move throughout the world, certainly how we perceive our patients. Then we have the history of race, racism, and medicine and science, and that one is largely through the work of Edwin Lindo. Some of you may know him. He is a critical race scholar. He is an attorney by training, has done a lot of writing. I always give Edwin a plug. If you ever get an opportunity to have him come and be your keynote speaker, you will have one of the best experiences of your life. Then gender and sexual diversity, which that is focusing on how we work with our LGBTQIA population, social determinants of health and health disparities, looking at bias and microaggressions. Another plug is for Dr. Jonathan Cantor, who is on our team. He is a clinical psychologist by training. His scholarly work has been around working mainly with white people on how to undo bias and microaggressions and how those affect those who are experiencing those. And then because we were experiencing a lot of people in our organization seeing things happening but not knowing how to intervene or how the language that they should use, they were asking for some bystander training, and so we have now added that to our to the list of trainings that we offer. So another way that we want to make sure that we are providing equitable programs and policies and practices is through an equity impact review tool. So when I first started, one of the things that myself and my dyad partner, the late great Dr. Patricia Dawson, did was go around and start talking to people and asking them about their programs and projects and looking at our policies. And one of the things that became clear is that people didn't have an equity lens to look through when they were developing policies or practices or programs. And we realized, well, why would they? There's no reason for them. They're not focused on this work the way we are. So we began to realize that we really needed a tool that we needed to develop. I was familiar with, you heard in my bio, I worked for Seattle King County Public Health. So the city of Seattle and King County had developed an equity impact analysis tool is what they called it. And I had adapted it for a couple of other organizations, and I said, we need something like that for our healthcare system. So in 2019, we began to work on that. And in fact, it was it was the last project that Dr. Dawson did for us before her untimely passing. So it is a tool that provides us a framework for decision-making for all decision makers at all levels. We know people are making decisions all the time around our system, and what has happened is that people have made a decision, they're ready to roll it out, or it's already scheduled for go live, and then someone finally says, well, did you run that past the Office of Healthcare Equity? And then they'll bring it to us, and we take a look at it, and we go, we're going to have to ask you to pause on that because you missed this, and this. And so then folks get annoyed and we're frustrated, and so nobody wants that. So we really have now began to kind of market and socialize this all around. We have, we actually have put that on our training schedule, so we have quarterly trainings about that. So that really at conception, people can start looking through this equity lens at the decision that they're about to make. And it has 6 steps. This is a summary that we do a full hour and a half training where we go through each of the steps in detail. But it looks at, first you want to look at the scope, who's going to be positively or negatively affected by a decision. Second step is to assess the community context. Who are your priority communities? What are their concerns? Third step is to analyze your decision-making process. One of the key areas there is really identify who's that decision maker. How many people have gone through a whole process, you're ready to roll out something, you thought you got the okay, and then realized that you didn't have the right decision maker in the room, right? So this allows you to make sure you're doing that before you roll something out. Then we want to clarify the purpose, and there's redundancy built into this because we want you to go deeper. And one of the things people always have to say, well, isn't there a shorter version? Can't we do this faster? And we say, no. That's why we're coming out with processes and programs and policies that were inequitable, because everybody just wanted to rush through it. We look at, is it, as our organization, is it advancing our anti-racist commitment? And then lastly, is there ongoing learning and engagement? Do we have a way to continuously get feedback, to update our communities, to continuously update them and them update us? So that's our impact analysis tool. The other tool that we have internally is our bias reporting tool. And that came about, again, during listening sessions on our side and on the medical school side, is that we have a workforce that, like any workforce, conflict happens. People have issues with each other. It can be from faculty to staff, staff to staff, students, residents, and although we have our administrative policies and processes and HR, people didn't feel comfortable always going to those, and so they wanted a way where they could report that something happened to them that they perceived was harmful to them, and wanted then there to be a process that could help that. So our upper campus, everything other than the medical school and the medical centers, what we call upper campus, had a bias reporting tool that was available to the people at UW-Medicine, but they just weren't accessing it. And so myself and Dr. Trish Critic, who is our Vice Dean of Faculty Affairs, brought a group together to look at developing a tool that would be very specific to UW-Medicine. So that became our bias reporting tool. It's a way of sharing incidents that include racism, sexism, ableism, discrimination, other behaviors that are just in opposition to our values of being an equitable and inclusive organization. So we launched this in 2021, and to date we've had about a little over 1,300 reports come through. They are from across our organization. All 7 of those purple areas report in, and we've really found that it has been really beneficial in helping people to realize that there is some place to go. People are hearing me, and there is another alternative. Although our HR folks are certainly a part of this team. But people wanted another way to be able to either come directly to our office or certainly report it through there, so that they are not feeling that they are isolated, alone, and not being able to address their harm. So another way we looked at addressing harm now is through restorative practices. And again, we're trying to focus on how do we make our environment better for everyone who works there. So we realized through an incident that happened now almost 4 years ago, it was 4 years ago, with faculty and students, that sometimes when conflict happens, we don't want to use our administrative processes and policies. Those are great. They have a place. They're necessary. We have to protect our organization. And for the most part, those are punitive and corrective and disciplinary. And while that helps, we want to correct somebody's behavior. Sometimes there's discipline. For most egregious acts, sometimes, someone has to leave our community. But what they don't provide is any healing. They don't provide healing to the person who was harmed. They don't provide any type of healing opportunity for the person who did the harm or for the community that witnessed that harm. So because of that incident, one of it was students that brought up the idea of bringing restorative practices into our community. Many of you know restorative justice, restorative practices, came out of indigenous communities thousands of years ago. Then they were brought into Western culture, just in the 20th century through corporations, through schools, and actually through the criminal justice system. Because even there they realized that we harm people in our criminal justice system to teach them that it's wrong to harm people. Doesn't make a lot of sense. So, and that is a quote actually from Fania Davis, who does this work down in the Bay Area. She actually is Angela Davis's sister. So when we do a training, we have a little video around her. So we brought restorative practices into our work to help us to both look at how to build community and how to resolve conflict in a way that is healing and restorative to the whole community. So we use circles, that's kind of the format and where they are. We use it to affirm our community values and build relationships, how we welcome new members into our community. One of the things we don't do a really great job of is onboarding people in a way that they feel like they're really valued and belong. We onboard them so that, here's your job, here's all the support you need for your job, these are the things, if you need help with your job, go to this person or that person. But there's no real formal way that we bring people together so that they actually, well, how am I connected to this person? And how is this person maybe connected to something else? So this allows us to do this in an intentional way. It's an intentional way for people to be able to speak authentically. Again, when you're in circle with people you're able to share perspectives, and then again, for conflict resolution. So just quickly, the three ways we look at restorative practices. Community building circles, that's where we're really focusing. We want to make that just a part of the way we do our work, bringing people together as they're onboarded. We'd love it to be part of our new employee orientation, bringing people together in circles so they actually get to know people, from day one. The second tier, that's tier one, is restorative circles, and that's when conflict has occurred. We do the community building circles because we hope that once you get to know someone, when conflict does occur, and it will, because we're people, it's not going to rise to the level where you're going to actually harm somebody. But if it does, which it will, we have this way of bringing people together in circles so that, again, that person who was harmed is in a supportive circle. The person who has created the harm can take responsibility and accountability for that harm in a way that still helps them to feel as a part of that community. And then the third tier is for re-entry. Someone may leave the community for a variety of reasons. If it's a disciplinary thing, someone was put on administrative leave and they're coming back, or it could be just someone was out on FMLA for a long time and is coming back into the community. And it's a way of bringing that person back in and letting the community be able to tell them, here's how we're going to support you. These are the commitments we're going to make to support you in order for you to continue to be successful here. And the person has to say also, what are they going to do to ensure their own success? So that was the 5-minute restorative justice training. So then the last thing I will talk about is our EDI climate survey and how we are looking at that as a part of our total employee experience. So we're looking at our equity, diversity, and inclusion survey. We have a well-being survey that is also done, and then we have an employee engagement survey. We like to survey people at UW-Medicine, and we realized that as we were surveying people, and these surveys are about 2 to 3 months apart, we were asking for each one of these areas to do an action plan. And finally, I will take credit for it because it was myself and Eric Ho, who is in my office, our Director of Strategic operations, looked and said, we're already oversurveying people. We seem to be burdening each of our leaders with having to write these plans, and these all intersect. It's all about how people are experiencing our community, how they're experiencing the workplace. And if we can bring those together and connect them, I think we'll have a better opportunity to make sure that people feel like that their environment and that their leadership and that their peers all are moving in the same direction and really focused both on each other and at our patients at the same time. So our Equity, Diversity, and Inclusion Survey was launched in 2023. It was an opportunity for us to get a baseline of EDI experiences across the organization. It included all of our staff, all of the entities in that purple from there. You will see the one area, Valley Medical Center, who's down in Renton, did not participate. It was launched last February. We had a great response rate for surveys. We had about 34% response rate, so a little over 10,000 people participated in that. The key themes that we found out of there are those you see on the left. I won't read all of those out to you, but certainly the diversity, people experiencing bias, and how we are recruiting and retaining were the top two. We saw where inequities and disparities exist in terms of experience. This was not a huge surprise, but great to see it, that our colleagues of color were certainly experiencing our environment differently, along with our colleagues who identify as trans and non-binary. So out of that came actions and recommendations. And there were 4 areas that we have asked all of our leaders to write action plans for. And those are there. Accountability around earning trust by demonstrating that leaders are accountable and following through on bias reports, as I talked about that bias reporting tool. Belonging and safety, so addressing disparities in belonging and psychological safety came out as a big one, particularly for our colleagues that identify as trans. That was a big one for them. And also, as people are looking at that psychological safety, this whole idea of retaliation kept coming out. People experiencing bias was the third one, developing support systems to reduce that frequency of bias and discrimination. That's a lot where our training is coming in. And then diversity, of course, increasing our diversity, particularly in leadership areas. So there are the action steps right there that I won't read through, but we wanted to make sure that all leaders had this framework so that we were really doing this work as a full institution. Because we're so large, we tend to do things kind of in silos, and this was really one of the first times that we've come together to put out an action plan that everybody is going to work on through equity, diversity, and inclusion. So as I mentioned, we love to survey people. So in the last year, we actually had 4 different surveys. We did our annual wellness, our annual workplace survey. That's the employee engagement. Our IT folks did a survey. We did our survey, equity, diversity, and inclusion from our office, and then we did our well-being survey as well. And as you can see, the overarching goal in looking at all of that is to improve our workforce experience, get feedback from all of the surveys, all of the leaders, so that we can put together meaningful follow-up action plans. So we're going to do that in June with a complete employee experience event. It'll be the first time that the leaders leading all 3 of those surveys, all 4 of those surveys will come together. And we want it to focus on leadership and how they are implementing the work plans from all of those. It's going to be a full day. And we want to focus on the leaders. That's one of the things we also haven't done a really great job at, is helping leaders to realize that we know you need support too. We want to make sure you feel like you belong so that you can then lead your workforce, and that then our workforce can take care of our patients. And just as it says down there, where we want to create a place where equity, well-being, and employee engagement are there to nurture exceptional care for our patients, our families, and our communities. So I am going to stop there and see if you all have any questions. Thank you. Questions? Yes. Is there a microphone? Okay.
Can you hear me? Oh yeah, hey. My neighbor got a karaoke machine. It's the best thing ever. But I got some practice talking in the microphone. But I'm really interested in the foundational modules that you developed. And are those something that are available or potentially you could share with other organizations to create our own or to even potentially use? Can you talk a little bit about that?
I absolutely can. There is my information. You can go to our website and see more in depth what those modules are. Right now, we have limited our trainings to we have quarterly trainings that we do, or months, I'm sorry, we have monthly trainings that we do for all of those modules. Those right now are limited to our workforce, and we want to share what we're doing. So if you're interested, just give me a call and we'll figure something out. Yes.
Hi, thank you. That was really fantastic work that you did there in such a short period of time. I'm Rob. I work for Peace Health. I'm a surgeon. And I'm getting the feeling that to avoid I shouldn't say that. Let me start this way. I'm sorry about this because it's really confusing and anxiety-provoking for me, for whatever reason, to talk about this. And so what I'm hearing when I hear things like equity, inclusion, diversity, is I think to myself, how do I make that applicable to everything I do? And so the question that I ask now, or I'm going to ask myself, is who are we missing in everything I do? And so, or every conversation and whatnot, because now that you take like a research protocol, for example, and you've run it through your clinical investigation, and now you're running it through the diversity and equity inclusion people, your shop. That is awesome. And so when I think about this, is that I have one question. It's leading to a question. Why was Valley excluded?
Yeah, great question. So we have an alliance with Valley, and so they have times when they are doing what the rest of UW Medicine is doing, and then other times when they're doing their own, sometimes they're doing their own surveys. They have their own administrative processes. They have their own administration. So our relationship with Valley is a little bit different than it is with some of the other integrated. So they just chose not to take place at this time. They actually did say they would take place in the next one. They would take part in the next one. Yeah.
Hi,
Yes.
I'm Jeff. I'm with Peace Health. I'm with Clinical Education. The Equity Impact Review tool, is that a tool online that we have access to, or is it homegrown through the university?
So we developed it. As I said, my partner, Pat Dawson, was the main author of that. It is up on our website. So it is available. We've presented it now at national conferences. So we want to share. We want everybody to have that equity lens to look through. Yeah.
Hi, thank you. That was incredible. I just wanted to hear a little bit more about the bias reporting tool.
Sure.
Makes tons of sense to me that you have that separately going through your office, but I also know you've got HR, you've got unions, you've probably got a Title IX office. So I'm just curious, what are some of the successes and challenges with integrating that with the other systems? And yeah, I'd just love to hear more about that.
Sure. I'll give you the 3-minute version of the hour-and-a-half bias reporting tool training that we do. So our bias reporting tool is online. It's a tool in RedCap. People have a little icon on there their desktop. So they can press it, a form opens up, they get to fill out the form saying what kind of bias do they think happened. Was it discrimination? Was it racism, sexism, general harassment, bullying? They can say what was the identity that was targeted. Was it race? Was it gender identity? Was it position? Because this was a faculty person and I'm a staff person. So they get to fill out all of that, and then they can tell us where it happened, who was involved. Was a patient involved? One thing we wanted to make sure is that this is not an opportunity for patients to report bias. We have another system called Safety Net for that. So they fill that out, comes to a coordinator who does the first triage. She gets back to the person, please give me more information. Then it sends to our bias reporting tool committee. I chair that committee with Dr. Trish Critic, who I said is our Vice Dean Faculty Affairs. And we take a look at it as a group. We look at all of them that come in, and then we do a huddle every week. And the coordinator will say, okay, well, this one needs to go to HR. We have members of leadership positions in all of our hospitals, nursing and administration, and we have our HR colleagues, our HR leaders for staff and for faculty, which is called Personnel Policy Unit, sit on that committee. So we'll determine right away whether it needs to go to HR, because again, sometimes it just needs to go to HR, particularly if it's going to involve a union. We want to make sure that we have that expertise there. Otherwise, it might come to a member of us and we do the follow-up. And that follow-up could be just a conversation with that person and their manager or supervisor. If it's faculty, it could be a conversation with that faculty person and the chair of a department. As I mentioned, Dr. Jonathan Cantor is a member of our team who's a clinical psychologist whose expertise is in helping white people to understand racism and microaggressions. And sometimes we just say, you need to have a conversation with Jonathan. And so he'll do some individual coaching, which might be a one-time conversation, or it could be quite a longer engagement with that person. So that's what happens with the bias reporting tool.
Thank you so much, Dr. Houston.
Thank you, everybody. My pleasure.
And we'd love to invite to the stage Dr. Yaw Nyame.
Good morning, everyone. It's absolutely delightful to be here. For the last few days, I've been talking to my wife about how I had to give this talk in Bellingham, and maybe we need to get a hotel room. And finally, I decided I'll just get up really early and drive to Bellingham. And last night, I pull up the calendar invite and I put it into my phone. It said Mount Vernon, and I was delighted to save some time. I'm also glad I didn't get a hotel room in Bellingham. So this is what happens when you bring a guy from Oklahoma to Washington. So let me see if I can get these slides to advance here. Just give me one moment. All right. So my name is Yaw Nyame. I've been in the Northwest now for almost 6 years. Time does fly. I came here for my oncology fellowship. I'm a urologist by training. I trained at the Cleveland Clinic and then came here in 2018. And you might be thinking, does a surgeon really serve in a position where they can do community-engaged work? And this is something that I face all the time because we are very busy in our clinical practice. But I think given what role I play in the management of prostate cancer, it's such an important opportunity to serve as a liaison between community, patients, and research. And that's really what I hope the message for today is. I do have some disclosures, mostly funding, and none of these impact the talk today. So I think a good starting place is to think about prostate cancer. It is the most prevalent cancer among males worldwide. It's the most common cancer in the U.S. for males, and also has the largest disparity of any cancer in the United States when it comes to death. And so here you see some statistics. Prostate cancer is the leading diagnosis of cancer for black males. It's also that for males in general in the U.S. 299,000 cases are estimated of prostate cancer among all men in the U.S. And if you look here, it's not only a leading cause of a new diagnosis in black men, but it's also the second leading cause of death. And I talked about inequity. If you look at the introduction of PSA, we've had a 50% decrease in death from prostate cancer across the U.S. Since the late 80s. However, I always look at this image and I think, the gap, the rate of prostate cancer death for black males is at the top. You have the rest of the U.S. population in gray at the bottom. And that gap doesn't ever seem to go down despite the fact that we've had tremendous improvement in prostate cancer care and outcomes over the last few decades. And I had a medical student approach our research team from Drexel that wanted to get involved in some research, and he helped us do this project looking at excess mortality and life years lost. And since the 1970s, we've lost 117,000 black males as excess deaths to prostate cancer, and it equates to 1.5 million years of life years lost over that time period. These are males that are often in their fourth, fifth, sixth, seventh decades of life. They are the economic backbone of their communities. They engender knowledge and stability and foundation in community. And this is a tremendous amount of loss. And what drives this inequity? I think we all understand that this is a complex ecosystem. It's rooted in structural racism and structural inequity that interacts with social, environmental, health, and biologic factors. And when we think about prostate cancer, for instance, we have the ability to perform a blood test that can lead to earlier diagnosis potentially. And so you can have this really incredible interaction between all of these factors and an ability to even understand that you should be asking your doctor for this test, let alone whether you can get that test performed. And then look at all these downstream things that need to happen, right? Once you get the test, is it a value that requires further evaluation? Do you have access to a specialist like myself to further investigate that, and so on and so forth? So this is really a complicated system. Usually here I start to talk about the natural history of prostate cancer in black males. It is different. So black males tend to get prostate cancer about a decade earlier in their life. They're younger when they're diagnosed. It seems that they have more aggressive cancers. The why is we don't know. Okay, so this is not necessarily an inherited biological factor, but prostate cancer is a heritable disease. So again, it goes back to that complexity of interactions. But I want to talk about the Center of Health Outcomes Research and Dissemination, a group that we started in the Department of Urology, and specifically PACT, which is our working group that's focused around equity. And I think part of the reason I wanted to highlight this, and I think this is the reason Devin asked me to talk today, was because what we're really looking at is developing the right ecosystem and partnership so that we can have representation of not only community members and patients, but also our expertise on the research side, right? And I think when we bring all those things together, we have the ability to really advance equitable care. And so this is what our structure looks like, and each phase informs the other. So we have a patient and community arm through Backpack. We have a quantitative research arm, which means people like myself who sit behind computers and look at data and come up with p-values. And then we have the qualitative and researchers and social scientists who humble us quantitative folks all the time by saying, hey, you could just talk to people instead of just staring at your screen. So, when I think about what we do, it's called health services research. You could call it public health. But we really are focused on patient-centered outcomes research. And what is that? Well, most of the time, I give credit to this slide to John Gore, my mentor, and I think he's really popularize the approach that we're using certainly within the field of urology, but I think has had impact in other fields, especially equity fields at UW. So I wanted to give him credit for this. But we always start with a question, right? And then we talk about comparative effectiveness research. So is doing X better than Y or just as good? And these research questions are usually like in a forum like this with a bunch of scientists or MDs, and we talk about what the important question is within our field, and there is a role for that because of the expertise. But wouldn't it be incredible if we just asked the people that we serve, our patients, to tell us what they think the priorities are for what we're going to do? And we can do that through surveys. We love surveys at UW, all right? And if we come up with the right questions, we can look through all of the published literature to understand whether or not there already is an answer that we just need to implement better. And if that answer doesn't exist, we can perform the studies ourselves. And ultimately, I think we all want to come up with this iPad-like tool that we can give to patients or a drug or an intervention that's going to improve their outcomes. And when I think about what we do, we're like a marketing firm. And I bring this up because when I got to Kellogg for business school, I was just this medical student, like bright-eyed, bushy-tailed, just excited to be with all these business people. And when I got to Kellogg, all they talked about was marketing. And after about 6 weeks, I was like, I'm like taking out all these extra loans and like I'm taking a year off from med school to like learn about Super Bowl commercials. Like, what are we doing here? But what I learned in my time at Kellogg is marketing is the lifeblood of an organization, right? Because it's those services that help you understand what you're going to deliver, how you're going to exchange your services, and it is more than just communication aspect of it. Understanding your market is what allows your business to be successful. And for us, when we think about delivering equitable care, it's really about thinking of the ways we develop, implement, and sustain interventions, and it's that cycle that we really are committed to. And we do that really on this pillars of something that is not new. Community-engaged research and community-based participatory research was really popularized in the 70s and 80s. It is a tried and true methodology, and I think many communities rely on it to deliver care in their communities. But what's a little bit different about what we're doing is we're taking this lens, and I think we're trying to apply it to some of the larger scale studies and larger scale interventions that we see within our field. And I think we're wanting to have a pipeline that allows us to do things in our backyard, but also affect national policy. And so we have a lot of partners that allow us to do this at University of Washington, Fred Hutch. We also have prostate cancer advocacy partnerships that really allow us to do this work. And a lot of this was funded by the state of Washington through the Andy Hill Care Fund. So 2020 seems to be a pivotal time for creating something new. I just started on faculty in July of 2020 in the heart of the pandemic. And I wanted to form an alliance with patients in our community to really think about ways we could advance the equity research agenda in prostate cancer to serve Black males and Black communities. And on the top far left corner is Ben Young. And Haley, who was at OCOE back then, was instrumental in connecting me to Ben. Ben Young and Victor Tolbert, who's tossing the football. He's a young Black man who's really was involved in the health awareness in the Kent community. And those two joined us via Zoom. And we hosted a lot of meetings, and we came up with a mission statement and a vision of how we wanted to grow Backpack over time. And for a long time, I would give these talks about Backpack, and it really was like the four of us. The other person involved was Dante Moorhead, who was a community health educator at OCOE at that time. I'm really proud and excited to say that now Backpack has a board of directorship who you see in the pictures. We have advisors. We're actually up to 35 advisors at this point, and it's really fun. I came in this morning and I get tapped on the shoulder and I look and there's Daniel Van Arsdale, who's sitting in the back of the room, who's backpack participant and member and someone who's helping us do the work. And so it's been a fun journey to see our organization grow, and all of these men are supported by our research team at UW. So our goals are to prioritize research questions, to develop patient advocate researchers, and to design and conduct impactful studies. That really was that mission that was derived from 2020. And I'll tell you, the first time I met Ben and Victor in person had to be a year and a half after all of these Zoom calls at a church event down in Kent. So it really has been a unique journey, you know, forged in the pandemic, but one that I think has really led to an incredible amount of work. And when I say that, what does that look like? Well, since 2020, we have generated close to $3 million of peer review funding through the Department of Defense, the PCORI, Patient Centered Outcomes Research, NIH, and other funders. So this is real research that's being done with research teams that aren't just myself and, you know, PhDs or MPHs, but with our community members being part of our team. And what I've learned through this process, and this is stolen from Kemi Dole, who's like my professional and life coach, is that patients from marginalized communities are participating in our research as a form of activism, right? They're looking for change in the communities that they're in. And so what we're doing in this kind of work is we're sharing our power, right? I'm no longer sitting in the ivory tower of a university with these great ideas, thinking about how I'm going to change someone's community that I'm not living in my day-to-day, right? I started this by saying I'm a surgeon. I spend overwhelming amount of my time at the Montlake UW campus taking care of patients, and then the rest being a dad and a husband, right? But having these partnerships and being committed to these partnerships has allowed me to understand what happens in the communities of these men who now are representing regions across the country. So I mentioned social scientists. The first thing that happened when we started this work was someone said, well, you got to interview folks in the sound. We really, across the sound community, to just understand what the needs were around prostate cancer screening. And that's really what we were interested in, is how do we do more screening. We ended up interviewing 29 men in Pierce, King, and Snohomish County. And the three themes that came out of this were there was a lack of information to support and support within the health system to promote Black men's prostate health and prostate cancer awareness. You can see the quote here, really, that when these men feel like when they go to the doctor, they hear about their cardiovascular risk, but not their prostate cancer risk. In fact, one of the things that we keep hearing over and over is, I didn't know that there's a 1 in 6 lifetime risk of prostate cancer in the Black community. I didn't even know prostate cancer was a thing for men to worry about, which is, as a urologist, I say, what? You know, but again, that's an important perspective to hear. Primary care physicians are the gatekeeper. And I think one of the things that we heard over and over again was the recommendation for screening is shared decision, right? But if your provider doesn't believe that you should be screened or in your screening tool, there's not much sharing of decisions happening, right? It's a one-way street where you may ask for a test and they may say, well, I don't know. What's interesting is there are certain patient populations that have an easier time accessing screening. So if you have a really strong family history, usually that's easier to make a case to your provider. But these men were appropriately telling us that they felt like their providers didn't understand that their race put them in a population at different risk that might benefit from screening. And so that was part of the discussion. And that trusting relationships helped overcome these barriers to screening. And so this is a quote from a patient who had shared racial concordance with their provider, and they felt like that helped lower a lot of barriers so that they could talk about those important health things. We did a survey, because we love surveys at UW. And what we basically highlighted here was that most primary care providers across the state didn't really believe that PSA testing worked, even though we have clinical trial data that shows that it reduces death by about 20%. And I didn't share it today, but we have some data to show that if we can screen potentially at younger ages, Black males, that we can reduce prostate cancer mortality even more because of the prevalence of it in the community. So the real question is, can we create equitable policy and health services interventions to address inequities in prostate cancer? Yes, we can, of course. So how are we doing that? In September of last year, we had our first symposium for Backpack. It was hosted at the Fred Hutch Cancer Center. We had 125 registrants, which surpassed what I thought we would get. And we built it into a two-phased, and as Daniel can attest to, very long 2 days, because we had all of our patient advisors fly from across the country to come to Seattle, which is that picture I showed you on the rooftop of the Fred Hutch. And then on Saturday of that weekend, we had a full-day symposium where patients came to the Fred Hutch, and community members shared in understanding what was going on in prostate cancer that was current. And then we had a lot of opportunity to just hear from community voices around what priorities they wanted to see addressed. And we're going to have that symposium again this fall. But the research that we're doing has come directly out of those interviews. And so one of the projects that we have is funded by PCORI, the Patient-Centered Outcomes Research Institute. And essentially, we've taken a backpack group of advisors and trained them to be researchers of early detection in prostate cancer. They've helped us develop what we're calling a virtual research community, which is going to be a survey population across the country. And that group is then going to come together later this year and develop a clinical trial, essentially, to address the top priority identified across the country in the early detection of prostate cancer. So we've been doing this work. It's been a lot of Zooms, but the pandemic has taught us how to use everyone, right? To use these technologies of I almost said telehealth, but to use computer technologies and to gather. And so we're able to get people from all the different time zones together on a monthly basis to do this work. And we are now to this portion of developing the virtual research community. So this is a sign up for it. I'm really proud to say that we have 500 Black males signed up across the U.S. for this in 2.5 weeks since we opened this. It speaks to our partnerships and the commitment that we've had in doing this work. So the other thing is we are using some cancer center funding to develop a tool to help with shared decision making, again, using the same platform. So this project is really focused on our catchment area, which is Washington State. So all of the participants, advisors, physicians, and scientists are all Washingtonians, and we are in the halfway point of this project. And basically what we've learned is that people want content that is not only culturally relevant, but digestible. So if you go online and you look for some of the higher accuracy information, it tends to read like medical students, like first year and second year materials, unfortunately, and that's well intentioned, but it's people just kind of want a quick one-liner about what they're dealing with, and then they wanted the opportunity to click on a link that might give them more detail when they're ready for it. The other thing that came through was the power of multi-generational framing. So having maybe an older Black male talking to a younger Black male about screening. And so we're in the process of figuring out how we're going to build this tool. There are a lot of content that people wanted, but the ones that really caught my attention was, first of all, just raising awareness that this is something for people to start thinking about as they approach 40, considering screening. de-emphasis of the digital rectal examination, which is not, I'm going to tell you right now, as a urologist, I know there's an older generation of urologists that would throw me off this stage. It is not a required test. It's not a good screening tool, okay? So if we can get people... If we can get people to screen by just getting a PSA test, you let me, the urologist, worry about the DRE and when to utilize it, okay? And I think that there are inequities. I think that a lot of folks don't understand that Black individuals in the U.S. are twice as likely to die from prostate cancer compared to their peers. So we're working through building this toolkit out, and it's really been a wonderful process of understanding how we're going to not only develop it, but implement it statewide so that this can be a shared decision-making tool that's available to patients and providers across the state. So really, I think our focus is on empowering Black patients to drive the science and the interventions. We've been really committed to that, and I think as our organization, at least on the UW side, grows, that we'll be able to have best practices to allow other investigators that have passions about communities that they are part of and they want to serve, use this methodology to improve cancer outcomes and health outcomes across the state and country. And I told you guys I grew up in Oklahoma. I'm a huge football fan, college football mostly, but since I'm in Seattle, I'm going to put up Marshawn here. But I think it's time to be action-oriented, right? A lot of what we've been doing is describing the problem. We've described the prostate cancer disparities problem for 50 years, but we have yet to have any impact as far as reducing the inequity. So with that, I'd like to thank the organizers of this fantastic meeting for inviting me here. If anyone has any questions about what we do, or if you know people in your lives, men, women, that are interested in prostate cancer equity, that want to participate in the work we do, we're open to all. And I want to give a special shout out to all of my fantastic collaborators and our research team, especially going to highlight Dante Moorhead. Dante has been in the community. Many of you may know him because he was at OCOE, and he's made this transition from being a community health educator to my PhD student, and be on the lookout for him because I think he'll be doing really big things. So with that, thank you again, and I hope you guys have a good rest of your meeting.
Well, are there any questions? Okay, we'll take a couple of questions.
All right, I'm going to go here first, and then there, and then we'll
Hi, my name is Amy Day. I'm here from North Sound Language Equity and Access Planners. And I hope I'm not asking something that's already clear to everyone else in the room, but I'm really interested and excited by the idea of patient-driven research. And a patient advocate researcher is not a term I've come across before, and I wonder if you could speak to that just a little bit and explain what that role is, how those people are in that role, and how that drives research.
Yeah. So as part of the Affordable Care Act, there was a creation of the Patient-Centered Outcomes Research Institute, and I think that really helped formalize patient-centered research, and part of that what has come out of that is the use of terminology like patient advocate researchers. For us, what that means is that we, either through advocacy organizations, typically, right, you have like a breast cancer survivor network, or in our case, prostate cancer survivor network, and we will reach out to those folks to see if there are any advocates that are interested in participating in a research project. The issue is what we talked about, the power imbalance. And so I think that if you're going to approach this work, there are some best practices. And I put those pillars of patient-centered outcomes research up, the 4 pillars. And I think transparency, honesty, trust always comes to mind for me, and meeting people where they're at. What we have to spend a lot of time doing is figure out how to create educational content to help our advocates get up to speed. it's not that they don't understand prostate cancer, right? They're living it. But it's when we come in here and we start talking about, randomized control trials and all this stuff that's really technical, we have to make sure that we have a training rubric to get them up to speed so that they can share in that conversation. So for the project that I highlighted, the first one, the early detection project, we actually went through a module on what is the prostate, like 1 week prostate anatomy, and then we had one on prostate cancer, right? Just general, what should you need to know, and then we went into early detection, and then we went kind of into the weeds on some of the research methods and how to develop a survey, and then our team sat together and like we would in any research meeting, we built the survey out, and what we found was that hey, some of the terms in the survey that's written are too technical. If I was a patient taking it, I wouldn't understand it. That kind of feedback is really, really impactful. So I said we had 500 or so virtual research community members, and they were all sent a survey, and 311 of them have completed it. If for those of you that know survey, a completion rate of like 70% is, when I was mentioned to me, I couldn't believe it, but when I think about it, it's the process, right? If you open a survey and you read the questions and it's easy to understand and complete, then you're going to finish it, right? So I think it's an underutilized member of a research team, and it's one that we put into everything we do. And when we get approached by industry, et cetera, about ways to increase and make trials more inclusive and improve trial, I always say, make sure you include a patient advocate, and that's starting to happen, I think, more broadly as more teams do the kind of work we do. I don't know if I answered your question.
Hi, my name is Erica Gadzik. I'm a family physician up in Bellingham. Thank you so much, first of all. This was such a wonderful presentation and really inspiring to see the ways that you're pulling together your academic background and your ability to draw in communities. I appreciated that whole thing.
Thank you.
One question that I have for you, you talked about we have 50 years of understanding these disparities, and how do you get people to the action phase? And that's something that I think about all the time, because I have so many wonderful colleagues and team members in my community who say, like, yes, this is a problem. Yes, racial health inequities are something we need to be doing. But then, especially with physicians, pulling other physicians or healthcare providers off of that, yeah, I believe this is important, and into that action phase is so hard. Do you have any advice or thoughts of how you have recruited your colleagues or helped folks come on to move closer to your level of combining your work in this way?
Yeah, that's the implementation side of things is the whole problem, right? So we have solutions that work really well, but we implement them very inequitably. And so the challenge is, it's huge, because I think the solutions have to be at policy levels, whether they're institutional policy, state and governmental policy levels. What we're hoping to do is generate the evidence to drive the policy and the best practices for implementation at the institutional level. So, if we learn that a shared decision-making tool is effective, part of what we want to do in our clinical trial is also like, what are the facilitators and barriers of implementation? We also strategically try to build all of our teams with every stakeholder that would be affected by an intervention present. So for our shared decision-making tool, we have a primary care physician from Kaiser. We have, in addition to other folks, just to make sure we have the voices. But the issue I think that we've seen in this phase is usually you have one or two really passionate physicians or clinicians, providers that are trying to do their part, but that's not getting system-wide. And I also think it's the importance of having someone like Dr. Houston and an office that sits at a high level that is also making sure that we have an equity lens as an institution, because we essentially need every healthcare system, every governmental system to prioritize this for us to make sure that we don't leave anybody out.
Well, that was Excellent. Can we get a round of applause for Dr. Nyame? We have learned from some expert leadership and providers, and when we come back from our 10-minute break, we're going to bring this down even more to our community level. So let's take 10 breaks, or 10 breaks. Let's take 10 minutes and come back and hear from our community panel.
All right, this has been an amazing morning, but hold on, because there's one more amazing speaker that you're going to hear from before lunch. I'm Chuck Prosper. I'm Chief Executive for Peace Health in the Northwest Network. I use he, him pronouns. I am also a board member of the North Sound ACH, and really honored to be part of the great set of organizations that are sponsoring this conference today. Peace Health is just doing its best to show up, to learn, and be part of this journey that we're all going on. What I'd like to do is just ask you for a moment to think about a really terrible day. Something has just happened. A family member, or perhaps yourself, is now in the emergency department at a hospital. There is a need to take you from the emergency department to the surgeries for urgent intervention. And then in a few hours, you'll be out on the floor in an inpatient bed, waiting, trying to understand what has happened to you, and to then make some very, very important decisions about your next phases of care. Think about, for you, the family, the trust that's necessary in the care team, the ability to simply just understand the language that the caregivers are using in the course of your care. And then to think about what it means to fully meet your clinical and emotional needs. When I came to Northwest Washington 5 years ago, I quickly recognized that in our organization, the caregiver and the provider team didn't match the communities that we served. There was a mismatch, and we needed to fix that. And so when I think about what the patients need, it really is that multi-generational, we're in it for the long run. So as Sue talked about, the power to affect real change, to foster a new generation of care, and how Rachel spoke about how this was in it, we're in it for the long run. This is multi-generational to get to a fully formed workforce that is exactly matching the communities that they serve and really understanding what it means for those individual patient needs. I think about myself as a leader and a change agent in supporting that from a workforce perspective. Dr. Houston, though, talked about that fully formed model at the University of Washington, where it also identified multiple populations, including the caregivers. And so what I would like to do before I introduce Abby Farmer is highlight to you that there is a piece of paper out here that's got a really, really important QR code on it. And Peace Health this year decided to put a $25,000 grant into the next round of scholarships, a matching grant, an intent for everyone else, whether it's an organization or an individual, to step up and help this next generation of healthcare providers and caregivers. And so as Dr. Houston described, thinking about all of the needs, Abby Farmer is a scholarship recipient. We are proud that she works in one of our Peace Health organizations, and a little while ago, she came and she schooled the executive team about what the caregivers need. Abby Farmer.
Hello, everyone. I am being brave. I wasn't necessarily expecting to speak today, so bear with me. Thank you, Chuck. I'm Abby Farmer, a nurse at Peace Health, but I've worked at Peace Health for over 15 years now. I'm just one diverse caregiver at Peace Health. I shared some personal experiences of racism that I have experienced over the years. We created a DEI group, created an anti-racism caregiver support tool that is available to our caregivers. There was nothing in place for patient to caregiver racism. I have experienced an insurmountable amount of racist comments and actions. So I saw a need, and we presented to the Northwest Network executives, and it was accepted, and hopefully we're going to present to the system-wide executives for Peace Health, and sky's the limit for our tool, so our bundle. Yeah.
All right, well done, Abby. We are extremely proud of you. And we recognize that racism exists everywhere. And so everything that we can do to speak about it, to address it, to refute it is so important. And it's just wonderful to see. I can just imagine 5 years from now, maybe you're going to be a keynote speaker at this conference, because we'll continue to support it. All right.
Thank you both so much, Chuck and Abby, to all of our speakers so far this morning. Next week, we'll be booking you for our keynote, Abby. I just want to share with you all also that I can flash this QR code up here. All of your donations from today's conference would be doubled up to that $25K mark. And I did just get a text message that one of our local providers who can't be here today just pledged $1,000 in. So woohoo! So folks, it's about that time to have a meal together, to build community. If you let us know that you were a vegan or vegetarian, there are plates of food waiting for you at the end of the buffet line, and we hope you enjoy. Let's all nourish and then come back this afternoon.
Please do not run and trip, although in a room full of providers, this is probably one of the safest places to do that. I will briefly introduce myself. My name is Haley Pritchett. I am the Chief Equity Officer for North Sound ACH. Many of you probably know our CEO, Liz Baxter, who's taking a very well-deserved weekend, one of her first weekends to herself in a while. So in place of Liz, I was asked to present for about 2 minutes. This will take just 2 minutes. I've also been in my role for about 2.5 months, and this is my first time at this conference, so bear with me. But I was asked to tell you all a little bit about North Sound ACH. So this, not to be confused with the North Sound Race and Health Equity Alliance. We are a partner, but you may see a number of us with these shirts, or the name tags, or the sweatshirts that are walking around. And let me tell you just a little bit about who we are. So some of you know what the Accountable Communities of Health are. We are one of 9 accountable communities of health in Washington State, and we focus on regional basis. So North Sound Accountable Community of Health, or ACH, is supporting the 5 most northern west counties in the state. And we exist, and I'm going to read this because I still don't have it memorized. We exist to create a just and inclusive culture and the necessary conditions for all community members to thrive. This is our purpose. We no longer have a mission. We've changed from having a mission and a vision. This is our purpose. This is why we do the work we do. So we aim to do this through a variety of ways. Some of that is through elevating partners who work across elevating vital conditions of well-being for people, some of which include meaningful work, which I'm hearing about in this room, lifelong learning, which I'm seeing in this room, and belonging, which I'm feeling in this room. So I love that. I hope that you are also feeling that. We also align to our purpose through investment in community, through catalyzing change, which brings me a little bit to our partnership with the North Sound Race and Health Equity Alliance. We are so grateful to be able to be in a place where we can support in planning and implementation. We have staff who are helping to support. We're also able to commit and donate to the scholarship fund as well. So if you haven't already, there are those little tabs on your table with a QR code. Please consider taking a look at that. I know if you all are feeling what I'm feeling, seeing and hearing what I'm seeing and hearing, you know the importance of scholarships like this. We don't have a pipeline problem. The people exist. We have an access problem. We have a systems problem. And scholarships like this can help to break down those systems barriers. So I said this would only be 2 minutes, so I'm wrapping up. I'm at time. All right, so I am looking forward to our next session. I'm looking forward to learning more from our next speakers. We have a kind of fireside chat coming up for you all. And so along with the amazing Devin Nixon, who I will pass the microphone on to, we'll also have our very own ACH's Dr. Colette Harris. And I might be a little bit biased, but I'm going to invite both of these amazing women up onto the stage. Devin, go ahead.
Hello again. Do y'all like my office chairs? You know more about me just by seeing the colorful chairs than probably everything else we've talked about today. I'm so blown away and so excited to finish out our day. But we're talking about some really sensitive stuff, and I'm hoping that if you haven't found an actionable step, if you haven't found a way to put your hand to the plow by now in this excellent community work, that by the end of our talk and hearing from our scholars that you will. I'm happy to introduce my friend and colleague who will be chatting with me today, Dr. Colette Harris. Colette grew up in Kirkland, Washington, seeing her father, a descendant of enslaved African people, labor in a glass factory, which exposed him to environmental toxins. A first-generation college student, she graduated with a BA from Stanford University, MS from Columbia University Institution of Human Nutrition, and medical degree from the real HU, Howard University College of Medicine. During residency at the Swedish Cherry Hill Family Medicine Residency Program, she cared for patients at the Seattle Indian Health Board and has practiced at Carolyn Downs Family Medical Center and Valleywise Community Health Center in North Phoenix and Unity Care Health in Washington, D.C., working to decrease the spread of COVID-19 and promote vaccine equity for unhoused people. She's written and spoken about the harms of training in our profit-driven medical system and is passionate about advocating for community health through an anti-colonial lens. Welcome, Dr. Harris. I'm gonna super briefly introduce myself because I don't think I've done that yet. My name's Devin Nixon. I received a Chuckanut Health Scholarship for $1,000 almost 20 years ago. And that was for prerequisites in nursing. I am the daughter of two descendants of American chattel slavery, both who suffered, I shouldn't say suffered, because when something's normal to you, you may not realize that you're losing years of life, but neither of my parents lived to be 70. I was a teen mom, and I was smart in school. I just clearly was doing other things as well, so I lost my focus a little bit, but just that one scholarship, really, it was really encouraging. It really made me feel like, wow, someone believes in me. Maybe I can become a nurse. and we'll talk more about each one of our journeys. But I am a nurse educator at Western Washington University in the RN to BSN program, and we're back at that little table, my colleagues back there. We've also just launched a Master of Science in Nursing program with 2 tracks, a leadership track and an educator track. I also practice in cardiology at Peace Health as a cardiovascular nurse practitioner. So I'm glad to be here today. I'm excited to have this talk. We're going to keep it real. That's why we're kind of aimed in so we can check with each other because the idea is that we're having this conversation not necessarily in a performative way, but an informative way. Thank you. Should I take this? Oh, thank you. Slide 97. 1 second. I'm scrolling. All right. So, Dr. Harris, why is mentoring important to you?
Thank you. I think that's a great question.
Can y'all hear her okay?
Can you hear me? All right,
Yes,
great.
okay.
So mentoring is important to me because I believe in self-determination and anti-colonialism. And I feel that communities that are systematically oppressed deserve to have physicians and advocates who look like them and who can really understand the racialized, environmental, and social determinants of health. So that's why I mentor, so that we can support folks from these communities in becoming physicians. How about you?
Wow. You had a really good answer.
Kind of like I planned it, right?
I think mentoring is important to me because I felt like no one was talking to me. I started my career in healthcare in 1997, and I was a file clerk in an ambulatory clinic, and I saw all these things kind of happening, but I didn't really understand what people were doing. I knew that I wanted a different life for myself than what I had experienced growing up, but I didn't really know how to upwardly social mobilize, if you will. So mentoring is really, really important to me because I know that sometimes all it takes is a hello or somebody just acknowledging your presence, asking you a question about yourself or your life to start building a relationship that can really change the trajectory of the futures. Yeah.
Thank you. The next question and next slide, if we can. So can you share about a discouraging experience that you had during the pursuit of your career of interest?
I could share about several. I think the one that was the most impactful was when I was in the 11th grade in an English class, and I was pregnant. I was visibly pregnant. And our teacher was going around asking everyone what were their plans after high school, what did they want to be. I went to a rural, predominantly white high school, so I was standing out without the belly. When she got to me, she said, "You're not going to go to college or have a career. You'll be selling Girl Scout cookies with your kid." And just skipped me. And that was really impactful at 16 years old to hear somebody say, nobody cares. There's no future for you. That was really discouraging. But I did get to do Running Start for my senior year of high school, and I got to come back and graduate the next year. I actually graduated from the community college 2 hours before my high school graduation. And when I saw that teacher, she was trying to peek at my baby too. I said,
I know that's right.
What about you, Dr. Harris?
Yeah.
Yeah.
Thank you for sharing. I know it's difficult to talk about these experiences. I think, similarly, experience discouragement at pretty much every stage. I received financial aid to attend a private Catholic girls' school, Forest Ridge, for middle and high school. And I remember the college counselor discouraging me from applying to certain schools, discouraging me from applying to Stanford. My mother was like, no, we're not listening to her. I also remember a time where a wealthy white classmate's mother was talking to my mother And she knew I wanted to be a doctor, and she was trying to discourage my mother from, having me pursue that as a career. When I got to Stanford, I learned that the pre-medical courses were really used to kind of systematically weed students out and exclude them from becoming physicians. And even the pre-medical advisors who were supposed to be guiding us, they actively discouraged me and just other students of color, first-generation college students from applying to medical school. And that experience is very consistent, I think, with what many students go through in the pursuit of a career as a physician. There was a recent study that looked at 81,000 students who had sat for the MCAT, the medical college admissions test, and students of color were more likely to report that they had been discouraged by their pre-health advisor from applying to medical school. So definitely consistent with what we see happening with folks across the country.
That's why we created this scholarship to help students who are being discouraged from pursuing health careers. Isn't me? Okay. How did professional mentorship affect your academic journey?
So the study that I was talking about, it also demonstrated that students of color, not unexpectedly, were less likely to have shadowed a physician. And so in my case, not having the familial or professional connections, I didn't have any shadowing experiences or access to, the internships, and also had to earn money, in my summers and the time when I had time. So, like an unpaid internship wasn't, I needed to also work. So I tried to do what I could to gain exposure to the medical field. So I had volunteered at Evergreen Hospital when I was in high school. And so summers in college would look like, I would work retail or admin to earn money and then try to kind of compensate by volunteering in the emergency department or at the cardiac health center. And I would say I didn't meet my first physician mentor until I was in graduate school, Dr. Rafi Khan. So I think I probably knew that I wanted to be a physician when I was in middle school, probably about 13 years old. So nearly 10 years into that educational journey, it was when I met the first physician who really mentored me. And it was during that year that I applied and was accepted to medical school, when I had that mentor who was very encouraging and supportive. So,
wow, 10 years in.
Yeah.
Wow.
Yeah.
I guess kind of similarly, I was a nurse. I was an LPN, a licensed practical nurse, when I met my first mentor. I worked in a cardiovascular lab, Skagit Regional Health, and I worked with a nurse practitioner named Joel Mextroth. And Joel was the first person I'd ever been that close to with that title. And we would run these stress tests together. And naturally, when you're in proximity to people, you end up talking to people. And so he was really the first medical provider that ever talked with me. He would say things all the time like, "You need to get back in school. You need to get in an ICU. You need to keep going and become a nurse practitioner." And I had no idea how to do those things. But he walked with me through that over years of working together. Interestingly, we were very different people. Just different politics, different experiences in life, very different. And so it's just interesting to me how he was a white man. We didn't have the same beliefs about, social justice and policies, but he still mentored me and was able to take what he knew, share that with me. And when I was accepted to Gonzaga University for the Family Nurse Practitioner program, outside of my family, he was the first person that I told his school. I went to the same school he went to. That's how I was like, where do I go? He went there. Okay, I'll go there. It was a great program, though. It was great.
Yeah, so, no, that's why this is so important.
Yes.
And so for folks in the audience, what should other healthcare professionals consider when mentoring Black, Indigenous, people of color students?
This is interesting. I think the first thing is people think in order to mentor, they have to be able to talk about really heavy social issues. They have to know something about the culture of the person that they're mentoring. They need to, I don't know, have all these qualifications. All you have to do is talk to people. All you have to do is be available. And our time is pretty packed, pretty precious, but even 5 minutes in a hallway, you wouldn't believe the difference that can make. When you're working with folks who are in entry-level positions, night shift, the kitchen, housekeeping, most of your company's diversity is probably found in there. And when I first came to Peace Health, I would say good morning to the housekeeper, and she would look at me like, are you speaking to me? Like it was such a shock, and it's like, yes, good morning. And I know that you know more about what's going on in that patient room than anybody else here, so come holler at me for a minute. But I think that's the biggest thing is that, it's mentoring is mentoring. And when we say mentoring BIPOC students, it's important to name it, but it also makes it sound like this is different than mentoring students. And it's not. It's not. So I think sometimes we acknowledge our differences, we celebrate our differences, but we have to recognize that we're human and we're all having a human experience, and something from your human experience can translate to my human experience, even if we're coming from different backgrounds. What do you think folks should consider when mentoring BIPOC students?
I really appreciate what you said, and I agree with what you said. I think about my personal experience, like, I had a very supportive family. My family made so many sacrifices for me, my parents. I'm so grateful. But what they couldn't provide, because they had a high school education, was that very technical, professional mentorship. And they didn't have that social network that, having a college education provides. And so that's where a mentor would have been very helpful. And I think back to even being at Howard, a historically Black university, and being asked by a classmate, oh, well, what do you mean you didn't know? Like, didn't your parents have friends who were doctors that you could have talked to? And it's like, no, I didn't. But, I needed mentors who were accessible, who were honest, and who were encouraging. And I think that anybody can provide that for our students. So,
absolutely. I think we're all mentoring whether we realize it or not. People are watching us, and they're learning from our actions, and they're receiving a yes or a no or a come or a stay away from the way that we engage all throughout our days, every day. But thank you for sharing that. I had this thought that it's not often, and I know this because my patients tell me all the time, to have two Black women, medical providers, to ask questions to talk this through. We've both had different journeys, mine on the nursing pathway, yours on the medical pathway, but I just wonder if anybody in the room has any other questions than these ones that we've talked about, or anything like that. What do y'all want to know in order to mentor the folks that you're coming into contact with at work and other places? And how might we be able to give some insight or encouragement to keep this thing going, informally or formally?
Yeah, definitely.
Hi, my name is Brittany Fuentes, and it's more of a commentary than a question because this mentorship program that you've instituted, I've been a benefit of both as a mentee and a mentor. And so I just really like to encourage everyone. It's true what you say. Everything you do affects people positively, negatively, or showing that you don't care. And so if you can take that time and encourage people, it really makes a huge impact. So thank you.
Thank you. Thank you.
Thank you. As you've spoken about the lack of a natural network when you were growing up and not having people that you could identify with, how would you suggest setting up just the entree points? So is it a LinkedIn group? Is it a social mixer? I'm thinking about just my organization, 3,000 employees. But that also means probably 3,000 to 6,000 children of those employees who need to connect. So what would be your recommendation on creating that networking opportunity?
Well, I can go first, but I know you have some insight as well. It's been said today about going to the community and not always needing the community to come to us. I used to coach basketball at a Boys and Girls Club with young kids, and I noticed after years and years of doing this that kids from a certain school were never signing up. They also happened to be kids that lived in my neighborhood. That's how I knew they weren't signing up. We all lived in a public housing project. And what I found out was these kids didn't have transportation to the Boys and Girls Club. They didn't have shoes, proper shoes to wear to play basketball. They didn't have a parent, sometimes home, if they did have transportation, to get them to and from. And so what I did was reached out to that elementary school in Bellingham, Alderwood Elementary School, and worked with the folks to come up with an after-school program to bring basketball to the kids there. And they got it, I mean, we know how the resources are available, right? They were able to write for a grant. We had school buses to take the kids home at a later time. And it was much more than basketball. It was other things the kids were interested in, but we went to them. And what I often find is that when we go to them, we find that there's somebody out there trying to do the work too. So just connecting with the folks who are trying to do that work. I think elementary schools, middle schools are so special to me. My husband's worked in middle schools for a long time. I could never actually work in one. But I love that age group as patients because they're just getting into this, like, tell me what I need to do, and like wanting to like be autonomous and take some control. So there's a lot of interest in that age group, but I think, you know, visiting the schools, going to their health classes, I know these are things that you all have already done, but especially in underrepresented communities, having people from their community that we can bring in and have that reciprocal relationship going back. Yeah, what do you think?
Yeah, no, I agree. I definitely think it's all about like the community partnerships, kind of going to the people in the community who are already doing that work. Like I know there's like mentoring programs that exist. I know in our, in the North Sound region, like we have a mentoring group for young girls, like Project Girl mentoring program. So, and programs like that, after school programs like Boys and Girls Club, YMCAs, going into schools. I know when I was at Carolyn Downs Family Medical Center, the residents there, when I was an attending practicing, the residents had founded a program where the local high school students could come in and, you know, they could shadow us and ask us questions, and then also like sit in lectures and workshops, like doing suturing workshops, and just kind of just gaining that exposure at a very early age and being comfortable in these environments and comfortable asking professionals questions. And So I really think it's all about like exposure and access, but can't forget about the existing, people doing the work and the community partnerships.
I also am thinking of something that Haley said about we don't need a pipeline, like the people are there. And I know I was a kid that was super curious about science and just tabling. If there was a table and I could go up and grab a little pamphlet on something, and it was written in like my grade level, I would soak all of that stuff up. The Magic School Bus, I love that. Bill Nye, I still think he is just, yeah, anyway, not to derail. But having things that are age appropriate and just available, just here, free, take it, have a cookie too, But yeah, great question.
Hi, thank you. All of your topics that you're discussing now definitely resonate with me. As a leader of color, I can remember times in my career in programs where, representation was either low or non-existent. And so as we think about need and the need to see people that look like you in similar roles, have you seen anything innovative taking place in terms of more on-demand support? Because over my career and my training, I've noticed it was all kinds of things that came up. And so I'm just wondering how far we could push this in terms of being available to be that support to someone else.
I talk a lot and I'm trying to
do
the
you go
awkward
for it.
pause thing so you can.
No, go for it. I mean, I don't know of like kind of, well, you go and then.
Okay.
Yeah, you go.
Okay. So this is what we are building. This is what we have actually built, and it's growing and it's getting big. So we have a Scholars and Mentors program where our scholars have access to a mentor, and these are people who voluntarily sign up and say, I want to be a mentor. And they answer a few questions, and one of those questions is about preferences on who you're matched with. Most of our mentors say anybody. Most of our scholars say, I'd like someone that shares this intersectional identity, or some don't care at all. And so I think that's the first thing to it's almost like a matchmaker process that's really low barrier, so that when someone is brought in, we can say, hey, we're not just giving you money, we're giving you access to somebody for 30 minutes a month. You two decide, is it a phone call, is it a Zoom, is it coffee? I did have one student, he was a 26-year-old black male. He was pre-med, finishing that, and he came to me and said, I'm taking a gap year. I just want you to know I'm not going to be around. And I said, well, why? What's the purpose of your gap year? Because sometimes there is a purpose, like Dr. Nyame getting your MBA and then coming back. But his thing was, I don't really know how to do the next steps. I don't know how to apply for MCAT and sit for this and sit for that. And I said, well, before you take that gap, would you let me introduce you to somebody? And I never got to even physically introduce him. I literally reached out to a colleague, Dr. Kevin Steele, who's a cardiologist, and said, hey, would you meet with this student? They worked it out. They met in grounds and grains at the hospital, and he didn't take that year off. And we know when folks take time off, the chances of them coming back and completing drop. So those are some of the things that we're doing with the North Sound Race and Health Equity Alliance that can certainly be replicated anywhere somebody happens to be at, yes.
That's why I wanted you to go, because I was going to say I don't know of anything in this region besides, this. But I think for me, just kind of being very available and looking for mentees. I go looking for mentees. I did. There was a period of time where I was on Twitter and I was in med Twitter or hashtag med Twitter or whatever. And, there was students that I really connected with. And then when it was time, I was like, I'm done with med Twitter. But I sent my messages out and was like, I really think that you'll be a great physician, and I'm here. I'm getting off Twitter, but I'm here however I can help you, And I was reading personal statements and continuing that mentorship relationship. So I think just putting yourself out there and being I'm here to help, I'm here to listen, I can, if I don't know or that's not my area of expertise, I can connect you with a person who is doing that. just really being available, being accessible, being that person that you would have wanted to have in your life.
Thank you.
I know they mentioned TikTok earlier as a joke, but I actually do that sort of thing. My kids told me I can't dance as long as I'm not dancing. I can make TikToks, and it's amazing what social media, just as simple like, hey, this is how I did this, or 5 ways that things you need to know about XYZ, and people are searching for that sort of thing and find you. So there's lots of different ways, and I think we all just have to do what's comfortable for us and not forced. I mean, there's a little discomfort at first, but you know, if you've never spent any time on TikTok, your first one might not grab that many people. But if you're on LinkedIn, like you said, mention on LinkedIn. Hashtag mentorship, hashtag mentee, hashtag healthcare leadership. I was definitely in the LinkedIn streets a lot. I still am, but when I was, early career, who are the people? Who are the people I can watch what they're doing and learn from them, even from afar? Most of them I never reached out to, but it was like, oh, she's there doing that. I can do that. Yeah.
Great question.
Well, there's one back here, and then I think we're going to move into the next segment. Did you have a question? Oh, okay.
So I have an answer, and nobody asked me a question. But so I'm echoing, though, a point, points that you made, which is when students come to you, I think it is really important that we find a way to connect them. And I wanted to make sure to say that out loud. There are often students that come to me, and I'm connecting them with physicians or researchers all over the country. And if I don't know the answer, I connect them with people that I believe would know the answer. Yes. So it's never an open, I never leave it with an open question. There's always, as you can see I'm demonstrating now, jump into the answer and offer that warm handoff to a student or to a curious soul who is looking for, because we're all seekers, right? Yeah. They're seekers, and so to the extent that we can be that for them, I think that's our role. We're all showing up and mentoring folks, so I just figured I'd say that.
Thank you for highlighting that. Thank you.
That's a resource. Often when we talk about under-resourced communities, and we always think of it as like financial or some sort of food insecurity or poverty, but under-resourced can mean not having the resource of a network. And so if we have nothing else that we can share, we can do that warm handoff. Thank you. Well, I think we should move into, sorry.
We can skip. We can skip.
No, I want to hear from you.
Well,
I know you mentor.
So thank you to both of you guys for letting us in on your fireside conversation. When I think about medical training and mentorship, I also think about the key nature of having your colleagues, so the folks who are students with you, who are your colleagues in residency, your colleagues, your co-doctors and nurse practitioners, and how big of a role those folks can play in supporting you and building you up versus breaking you down and making your life harder. And I know as a medical student, I knew about racial healthcare disparities, but I didn't understand how different it was what my classmates of color were going through. So what I'm wondering is if you guys could share things for the people who are in your life now or who were in your life as your co-trainees, and what they did to help build you up and keep you going, even if they weren't in the role where they were ahead of you, what they can do when they're in that journey with you.
That is such a great question, and I had that in my notes that I forgot to say it. So I'm really happy that you asked that question. So when I was a resident, so I had gone to medical school at Howard. I had done my intern year there, and I transferred from intern year at Howard to second year at Swedish Family Medicine residency program. And even though I had grown up here, it was kind of a culture shock for me because I had been in DC for such a long time. And pretty much, I would say nearly every shift that I did, my inpatient rotations, I experienced a microaggression. And I think I was just constantly, misidentified. Everyone assumed that I was literally everybody but the doctor. And what my residency colleagues did was when I would tell them what had happened, they didn't gaslight me. They didn't say, "Oh, are you positive that it was, racial, or, it may just be in your head, or you're just a suit." They didn't do any of that. They were like, "I'm really sorry that happened," and they would just, encourage me and just be there for me in solidarity. And I think that was so important. So even though I was experiencing that from the hospital staff, I knew that I could always go back to my colleagues and that they would kind of help me through it and not deny that it was happening. And they also, when I was there, we were trying to come up with a method for, kind of reporting these incidents, just like how safety incidents are reported. Like, we started just kind of reporting the instances of racism that we were experiencing, through these portals as well. So I think just listening and being there in solidarity, that was really important for me, and I won't forget that. Great question.
That is a great question, and I'm glad you had that experience. That was not my experience. It was very traumatic at every stage going through school and in practice, constantly dealing with things that my colleagues weren't dealing with and not really having anybody to talk to about what I was dealing with. I had a pharmacy student with me one day, and we were talking and breaking for lunch, and he said to me, "Does every patient talk about race?" And I was like, "Oh yeah, that." Yeah, not every day, but most of the time. They're shocked to see me coming in as the provider. But just him naming that, and this was an Asian pharmacy student, so my thing was like, so they're not asking you this? But there's that assumption, right, with STEM, and that's just another stereotype, right? So I was stereotyped differently. When I last worked as a bedside nurse, I played this game of how far can I get in my 7 a.m. to 7 p.m. shift without having somebody, not just patients, but colleagues, family members, somebody racialize me in a negative way. I got to 11 a.m. in a full calendar year. And so I think what colleagues can do is understand, if my demeanor is not the bubbly, what everybody else is talking about and doing, it might be because of something that happened behind a door that you didn't see or hear. And I don't want to talk about it all the time. It just comes with the territory. So, great if folks want to be an ear, but not everybody wants to talk about it. I want to forget too, but between something happening and forgetting about it, I might not be smiley. I might not seem as I don't want to say friendly, but folks go out after work. Invite the people that you work with, even if you don't think they fit in with your group. Things like that. So just know that your colleagues are having a different experience. Whether they tell you or not, they're having a different experience. And try not to misinterpret the way that they guard that for not being interested in socializing or, some of the other things that folks do professionally that often also lead to promotion. A lot of times you have to be in that room or at the golf tournament or at the fundraiser in order to be promoted. But if no one's inviting you, it gets really tough. So I hope that's helpful. Sorry, her answer was nicer.
No, and just to go off of what you're saying, I think the reason why that was my experience in my residency program, that was very intentional on the part of the program, right? That was in terms of who they were kind of looking for, the culture that they were developing, the educational programming that they were providing to their residents. They did like race-based caucusing. It was all very intentional that I think I had that experience because that's the culture that they were trying to kind of cultivate within the program.
Well, this is the part where we get to transition into the stories, but thank you so much for this. It's always so great to see you. Thank you for your work. Thank you. I think I'm more excited about this conference than the ones we've done in the past because we finally get to see the fruit of our labor. Many of you have donated in years past. Many of you have been watching and seeing what we're doing and checking it out. But for this next little bit, we're going to hear from some of our scholarship recipients, what they are doing out in the community, and they're working now. They are licensed. They are practicing nurses, nurse practitioners, physicians. So as you watch, I just encourage you to really hear the message and the story that they are communicating. This process of creating this workshop and going through and helping people tell their truths and what they feel safe sharing is really deep. And sometimes it feels like it goes by really fast. But just, I invite you to just open up and sit with it and then please consider keeping this work moving by networking, by mentoring, by donating. Thank you.
Dad, I remember you woke me up every morning to get ready for school. Before I left, you would touch my head and speak a blessing over me, always telling me how strong and powerful I will become and how I would put our clan's name to the world. In a world where girls didn't stand much a chance, you always believed in me. Daddy, I remember when there was a famine and drought and one meal a day was the norm. You would eat half and save a portion for my leftovers the next morning so that I can have 2 meals instead of 1. Daddy, I remember when I passed my national exam and you were really worried about my high school tuition fee. Our neighbor told me that you wanted to sell our land or our home to take me to school. You were ready to make huge sacrifices to make sure that I got an education. I remember that fateful day when my mother called and said you had wandered off in the middle of the night. You woke up at 1 a.m. to go to the bank and ended up in a stranger's home miles away. It was the beginning of a terrible illness that no one in my family or village knew about. The next time I saw you, you didn't recognize your little girl. You greeted me like a stranger and told me my face was familiar, but you couldn't remember my name, which is also your clan's name. My heart was broken into 1,000 pieces. I later learned the name of the monster, dementia, that robbed you of my name. The day I graduated, you were supposed to be there, but you were not. You were hospitalized. You were in a coma. Daddy, I want to tell you that your little girl is doing fine. Your laughter always echoes in my ears, and your face is engraved in my heart and mind. I
always call on you when things get hard. I haven't let you go. I love you, Daddy.
I want people to know that unconscious bias is real, and it contributes to burnout as much as being overworked.
As a Black nurse and former CNA, I am expected to be more than perfect in my work. I am not given an excuse for breaking any policy. The word human error does not exist for me. Anyone can make a human error, but not a person of color. One of my partners once asked me, "How do you become so good at your job, studies, and raising your family all at the same time, and you do it so perfectly?" I told her because the word error does not exist for me. I got 4 awards for being a team player and providing great customer service in my 5 years working in a facility. All in all, for a person of color to survive in healthcare, we have to live and abide by the laws and policies, which makes us be so good at what we do. There are lots and lots of things that go on that we painfully swallow after working hard and not being appreciated. But instead, we're expected to deliver more.
I'm grateful for the opportunity to help solve problems and positively impact people's lives, to hear them the way we all want to be heard.
As a nursing educator, I am grateful for the opportunity to influence the lives and journey for so many future nurses. I enjoy making a positive impact on the learning experiences for students, especially those from underrepresented backgrounds who have shared that they feel a greater sense of belonging in the classroom because they have a professor who looks like them.
Gosh, if I had a magic wand, I would probably not change anything about how I'm expected to show up. We do a lot for our patients, and I love going the extra mile. I have worked for over a decade in the healthcare field. With regards to community healthcare, you get used to making miracles happen with very little. When I meet someone who does not have community healthcare experience, I feel very lucky because those environments have given me something you just can't get anywhere else.
My culture as a person of color, as a Black African woman. My culture helps me appreciate my work, my partners. It helps me thrive and get daily work satisfaction.
My dad is a quiet but wise man. I remember one day he picked me up from school and asked the usual how was school questions, but then he was quiet for a while and said, "You're smart, I know you'll be fine, but keep working hard. You have to work 10 times as hard to be seen as equal here." My dad was an engineer, and he came here with my mom from the Philippines. Over time, I understood more of what he meant. The change in people's demeanor and willingness to include me in conversations when they find out where I went to school or what level of degree I have. I feel like I have to prove myself before I'm accepted as competent. I wish I didn't feel like I have to constantly assess how I'll be received and consider how I can demonstrate my knowledge and skills so that my perspectives are valued equally.
This is a hard question. I have a mentally ill family member who is a missing person for 4 years. Their absence completely affected my mental, spiritual, and emotional well-being. Their experience inspired me to pursue a career in healthcare. I also have a child with special needs. I would say that the experiences that I have had with my family have made me a better provider because I see my patients and have some lived experience with many of their struggles.
Devin. I met her at Peace Health Hospital. I observed her without her knowing I was doing so. I was impressed, elevated, and left with questions and wanting to know more. She then came close and had a chat with me and allowed me to watch her do her rounds on a patient. She had to pull out something from her heart. I forgot what it was, but I think it was a center line. I wondered how she made it through the systems. She shared part of her background story, and I made up my mind that I can do it as well.
I think that the knowledge that people believed in me this much was a huge motivator for me to keep going, especially when things were challenging. It has always been easier for me to criticize myself and not see the value of my efforts. I believe sometimes all a person needs to be successful is the knowledge that they are seen and that people believe in them.
The scholarship made me feel like I have good people who got my back and want me to thrive. It inspires me to work hard and be better and make them proud that they helped to get a great nurse out there. My family is also very grateful for their support. When we got the support, my husband literally made a sigh of relief because our income was affected as I had to create time for school. He got hurt, so he does not work, and I am the sole breadwinner.
None of the many nurses in my family have a master's degree, and no faculty in my nursing program looked like me. This scholarship signified my community's belief and value for my lived experiences. I realized that I could continue to see few racial and ethnic minority nurse faculty or administrative leaders. I started to wonder, as someone who's always enjoyed education and research, if I won't pursue a graduate degree in teaching, then how many other minority nurses will? Now as a nurse educator at Whatcom Community College, I am an example for students of color, helping them to picture themselves as leaders. I believe the upstream intervention of scholarship assistance is one that will have lasting downstream effects for reducing racial health disparities and inequities in education. It certainly has supported me.
I have worked the majority of my adult life towards this profession, not for money or prestige, but because I feel a deep responsibility towards my community and I love my work.
Of gratitude for everyone who contributed their stories and their voices, and to Monica Kohler and Devin Nixon for working on that video and sharing that voice with us in the room. One more round of applause. So I just looked at the clock, and I also just checked in with my other organizing team cohort friendos, and I said, hey, do I have permission to off-road a little bit? And they were like, yes. So I don't usually bring my cell phone on stage, but I sure did this time, homies. And the reason why I did was because I would like to set a timer for 15 minutes. And the reason why I'd like to take this 15 minutes, and this is offered through invitation, if you need to do something else, take a breather, absorb what we've just heard and those voices, please do that and take care of yourself. But I'm looking around these tables, and I would love to take this opportunity, this 15, for you to share with your neighbors what is your one next most elegant step in addressing healthcare equity. We talked about power and influence when we started this day. We've talked about opportunities to give and to mentor, and about stories and inequities that we see. What is your next most elegant step? Thanks, Adrienne Marie Brown, for those words. Next most elegant step. What is the one action that you're taking from today that you want to take? What's that step that you are going to do? And I'm gonna time it. So I got my timer here. It's gonna be set for 15 minutes, and we are just going to be at our tables with one another in conversation. All right, and go. shared a few into the room. Maybe just 1 to 3 elegant steps into the room, we could inspire action with one another. And so I'm wondering if anyone in this room, yes, I'm lurking with a microphone in between the tables, to see if anyone would like to share their elegant step. For it. Where are my extroverts at?
Alicia is from DV SAS. Is it okay if I share what you said? She's from DV SAS, and victims of domestic violence are often, also from. She said that, sometimes people come in needing support, and they have providers or experiences with hospitals or ERs or doctors where they didn't get their needs met, or they had a really negative experience, and instead of saying like, okay, we should avoid that person in the future. Like, how do we bring restorative justice practices together with those providers and those systems to help them learn, like, how do we support somebody through a sexual assault or a scary experience? And so bringing those restorative justice practices to, using a nonprofit that's there to serve patients, coming together from client and provider to learn together.
Thank you. And thank you, Alicia. That's amazing. That's amazing. We got one right here. Yeah. Is it Cedric?
It is Cedric.
Ooh, it's Cedric. Cedric, what's your elegant
I'm not going to
step?
stand up. I've got chips in my hand. It's the whole thing. But, so the conversation about mentorship, I think sometimes it can be overwhelming to think about, I have to have a tremendous amount of time and like very specific expertise or advice to give to be a mentor. But that the conversation got me thinking about just the power of visibility in the community. So anyway, twice in the last year, I've had 2 different people ask me to come, meet with or just like show up at events with groups. One particularly with elementary school children at the most diverse school in Bellingham School District. So anyway, my step is I'm going to reach back out to this person and find out how I can participate. Because, I think just, being in a room full of small kids who can just, see a black man in Bellingham who has a unique job and, that could be valuable for those kids, and I would get a lot out of it. And it doesn't have to be a super formal mentorship experience.
Awesome. Thank you so much, Cedric. Is there anyone else who would like to voice a step into the room? This is also a great way to make accountability buddies for your elegant step. If anyone needs accountability buddies, this is the offer for an accountability buddy. All right. Get it, Devin.
Our next elegant step was to continue, because sometimes this work can be exhausting. It can be burnout. It's extra work for people who have full-time jobs and are wearing a lot of different hats. And, you get people who jump in and people who jump out, and you go, okay, why are we killing ourselves, to keep doing this thing? And then we have a day like today, and we see our community show up, and we hear from the folks who are benefiting from the work, and we're all learning and growing together. And it's like, okay, it's not fancy, but the next elegant step is to continue learning, continue networking and collaborating with community organizations, continue mentoring, just to continue. So that's my step.
All right, folks. I really hope that everyone, if you're a goal writer, then please write your elegant step down. Please enlist your new friends at your table to hold you accountable. Maybe share your digits. Yeah, you could totally text each other to hold each other accountable to your elegant steps, or just to celebrate the win, right? Like, how cool would it be if Cedric texted Xenia and is just like, I totally went to that classroom, here's a picture of me. I would love that, and I would love to hear about it. So please, take those steps with each other, take those steps in community. And speaking of community, I get to bring up one more of the founders of this work and this process. It is our good friend, Dr. Erica Gatzik.
First question is always, will I be tall enough for the microphone? But I wore the big curl shoes, so hopefully. Hi, everyone. My name is Erica Gadzik. I'm a family physician up in Bellingham, Washington. And it is so good to be here with you all today. You know, this conference started over Zoom 4 years ago, and one of just the great joys for me today is see so many of the faces that I met and connected with last year and to see this group growing and evolving. So first, I want to thank each and every one of you for taking your time. You know, it's a sunny Saturday in the Northwest. It's like gold. And you guys are here today, which means a lot to me because this work matters. And as Dr. Houston said, no one person can own this. This is all of our responsibilities. And with that, every single one of us can be the catalyst to go out to our organization, to our family and friend group, and say, hey, this is not just my responsibility, this is all of our responsibilities. So how do we work together as an organization? How do we push the leadership of our organizations? How do we connect with colleagues and friends who believe that this is important, but maybe haven't moved to the action step yet? And that is the work that we will continue to do together for the years to come and hopefully keep moving forward. You know, it's been interesting. 4 years in, I was thinking last night about how my practice has changed, because so often, you know, I'm a physician, and what healthcare providers want is we want to know, what should we do that changes our practice, and what's something concrete, and, you know, what does the guideline say, and how can I be doing that better? And I was thinking about, you know, on this journey that I have gone through to push to educate myself, to push myself out of my comfort zone, to be more mindful and more action-oriented, what has changed in my day-to-day. And, you know, I just want to share a couple of examples of what that has looked like for me as a healthcare provider, to see if any of these are applicable, or if anyone has feedback to me on these. I always welcome that too, so let me know afterwards. One of the things I've realized that, you know, in many of our jobs, and especially in healthcare, it's no one size fits all. I need to do something different for my patient who is at higher risk for prostate cancer than for someone who is at average risk. I would not talk to my teenage patient the same way I would talk to my 3-year-old patient. And so with that, you know, I have been trying to be really intentional about thinking that if it's guidelines to say that I address what's different for each one of my patients based on their age and their background, why am I not also thinking about their lived experiences? And how do I bring that mindfulness into each and every interaction that I have? I've shifted my language. I've made sure that I talk about systemic racism as the factor that impacts someone's health, not about their race, because someone's race isn't a problem. That's, you know, a construct. But systemic racism and the chronic stress that puts on someone's on a daily basis throughout their life, that has real health implications. I can't remember which one of our speakers said it today, but I think it was one of the panelists, maybe it was Vinny, who said that people get so worried about being uncomfortable that they don't realize that their patients are not going to be comfortable if their provider is uncomfortable. And so I have pushed myself to get more comfortable, to name systemic racism with my patients, to say, hey, I know that you are at higher risk for this, or that we might worry about you having higher risk for this because of what you experience on a day-to-day basis, and I want to make sure that we are being extra proactive with our care for you. One of the ways that I've changed how I practice is that I'm more intentional with telling someone my worries for them in a proactive way. So very often in family medicine, someone has a symptom and you're like, hey, I think this is probably fine. Let's check a couple of labs. And I think if those all come back normal, we're gonna watch and wait. But now I will say, hey, as a person of color, we have evidence that you may be at higher risk for having delays to your diagnosis, or having us miss something and have a delay to you getting care. So if any of these symptoms is continuing, if you are having any worry or ongoing thought, I want you to have a really low threshold to come back and see me, because I want to be sure we are being extra proactive with you. And so That's my way of saying, I never want to ignore your concerns. Please come talk to me with your concerns. And so those are some of the ways that I have tried to work what I've learned into my practice. It's going to look different for every single one of us in this room. What I want you to challenge yourself to do is to think about the words that you use, if there are gaps in your own education, if you can take the time to learn what you're doing more, share what you've learned. And then I always tell my patients, listen, I take feedback. So if I say something today that is triggering for you or that makes you feel less comfortable, I don't care if you send me snail mail or send me a portal message or tell me in the moment, but however you feel most comfortable, know that I want your feedback so that next time I can do better. And I think that naming that is a powerful thing to do, to open the door to someone, because there's a power dynamic, and it's really hard to give anyone feedback in the moment, especially if you're like from the passive-aggressive Northwest. And so sometimes opening that door can be helpful. So that's what I was processing, over the last couple of days, because I am always trying to figure out what my own actions are and how I can make this work be something that I am thinking about daily, not just once a year at a conference. And then reflecting in the conference today, listening to Dr. Nyame and Dr. Houston, I loved the emphasis of seeing what these big healthcare systems, University of Washington is such a leader in our community, and we have so much to learn from someone doing this work with a large team. And I think the challenge for each of us in this room is to say, how do we take what they're doing and bring that back to each of our organizations? Because that's a hard ask, right? Like, we're not UW. My organization is a wonderful organization, but we do not have the resources of UW. But how do we take pearls from what they have taught us today? Is it bringing back some of the surveys they mentioned or some of the tools they've developed and pushing our administration, our colleagues to work those into our practice? When I think about, the wonderful panel that we had with our community leaders, with Katrina and Sylvia and Vinny, I think about how each of their lived experiences has made them uniquely able to meet the needs of their community. And it was one of our speakers last year who said that if you have lived through inequity, it's like having 10 graduate degrees in inequity. And that makes me think of our scholars, because that experience that they bring through their lived experience is so critical. And if we can support someone who has 10 degrees in inequity and get them onto the next degree, that's a great return on investment in terms of bringing really, really well-informed folks who really understand the situation and what can be done about it into the room and into the leadership positions. In terms of, thinking about Katrina's words about helping birthing individuals, I do labor and delivery and prenatal care as part of my work in family medicine, and what I've found is that so often someone actually can get really medically appropriate care, but it's how they feel during that experience that leads them having a traumatic experience or not. So you can have an experience that's actually quite scary and leave being like, wow, that was great, I felt so well supported. And I've had patients tell me that before. And you can also have an experience that actually everything went exactly medically, like there were no medical mistakes, your team did a great job, but if you were left feeling unheard, unsafe, out of control, like you did not have autonomy over your body or your birthing process, then you might leave traumatized. And so having folks who understand their communities, who are doulas, who are doing that work, it just can make such a huge difference in how someone then carries forward raising their child and how welcome they feel and how safe they feel in the healthcare system for the rest of their lives. And then during our conversations about mentorship, thank you again to Devin and to Colette, who are just such wonderful, wonderful leaders in our community. I'm thinking also about what Rachel said about how we're years away from race concordance. And we want to be focusing on what we need 10 years from now, but we also want to be focusing on what we can do right now, today. Which brings me to some good news. There is something you can do right now, today. And I wonder if you'll be surprised when I say, check out the North Sound Health Equity Scholarship. One of the really cool things about this organization's scholarship is that it gets money into the hands of individuals who need it to support their families, to support their careers, to keep them from taking that gap year. and it goes out really quickly. I mean, money comes in and we use it to support individuals who are then, as we heard from Abby today, doing really cool things at their organizations. And I know that many of the folks in this room have already given and donated, and I know that many folks have their own financial needs. So my challenge to you today is, if it doesn't feel right, well, ideally, give whatever feels comfortable to you to support these wonderful scholars. But if you don't have space, reach out to your community. We all have a network. We have aunties and grandmas and colleagues in all different arenas, and spread the word about this great work. And the next time you're talking to someone and you're like, wow, did you hear about this thing in the news? Or wow, I was thinking about this today. Say, hey, there's something we can do about this. Do you want to donate to the scholarship? The trainees that are coming out of this are amazing people, and they deserve our support, and we can help make their journey a little bit easier. So I know that, from my training years, there are times when just having an extra $20 show up to pay for gas that day makes a huge difference, especially with all of the debt that comes with medical education. And so know that any amount that you can send towards this wonderful group of trainees is meaningful and makes a difference and supports them in becoming our next generation of healthcare leaders. Okay, and with that, I think we should probably transition to final wrap-up and getting you guys out of here to enjoy the day. I don't know if I have slides behind me or not. Maybe can you click through, or can I click through? Do I just do this? Whatever you want to do. Okay. I also can do it for you. Yeah, there it is. Oh yeah, perfect, QR code. Well, let's give that one more minute, and then maybe we can flash through the thank yous for everybody else. Just, how about each time I say thank you, just move on to the next one? Okay, great. So first of all, thank you to our conference speakers. It was such a delight to hear from everyone's insight and perspective today. And I just always welcome the chance to leave feeling energized and inspired and committed to this work. Thank you to our conference sponsors and community partners. Believe it or not, it takes a lot to make this day happen, both in terms of financial contributions, contributions of staff time and resources. Thank you to everyone here doing photography and media so that we can capture this and share this information in the future. But this is a really wonderful group of organizations that has said this work matters to us, and we want to put our voice and our resources behind creating this conference each year. So thank you to each of these sponsors. Thank you to the planning team. This list grows and expands each year, and each of these individuals has done so much to make today happen. So I'm so grateful to each and every one of them. And then a special thank you to Monica Kohler, who does the beautiful work with connecting communities to highlight the voices of BIPOC individuals in our community, and in particular today of our scholarship recipients. So with that, final announcements. You can stick around, trade information, trade phone numbers, trade emails, try and make sure that the connections you created today are accessible to you throughout the rest of the year. If you need to, or if you would like to obtain CME credit, don't forget to fill out that online survey. If you are interested in joining this work and in partnering with the North Sound Health Equity Alliance, we are always looking to expand our connections in the community and keep moving this work forward. So please don't hesitate to reach out. We've got our email up above. There's also a few business cards on each table. I have more in my pocket if anyone needs them. And ending with one final challenge. When you go home today and your spouse or your colleague or your child or your mom asks you how your day was, I want to challenge you to talk about the conference, share about something you learned, and see how you together with the person you're talking to can take one next step. One elegant step. Yeah. Okay, guys, thank you. Have a great day.